Oncology Forum, and which is a part of Oncology Forum. So it is really a pleasure for me to invite Professor uh, Thomas Lowe, whom I had met quite a time back, and he had taught me. That time we were talking about salvage nasopharyngectomy, and it is honor to have Professor Raymond also along with us, and our national faculty, Dr. Sarbani and Dr. Shiva will be there, and esteemed panelists from us. So we will just share whatever you people have gained, and because we see just few minuscule patients we see, and we want to learn from whatever you are doing day in and out. So I welcome you all, and I think we will start off the meeting right now. So I will invite Professor Thomas Lowe.
Thank you very much.
1 minute, Professor. So I will just introduce you that Professor Thomas Lowe is a senior consultant, Department of Otolaryngology, head and neck surgery, and he takes special keen interest in head and neck surgical oncology at National University Hospital, Singapore. As a group chairman, medical board, National University Health System, he has been his interest has been on nasopharyngeal cancer, especially in screening programs and early diagnosis of NPC. And he heads the head and neck tumor board there at NUH, and he has received multiple teaching awards for undergraduate and postgraduate. He is presently having 3 grants and key collaborator in at least 10 concurrent studies. And he teaches well. That's what I know. So I will just share one of... Okay. It's not moving. Yeah. So, Professor Thomas Lowe, I don't know whether you remember this photograph or not. And when I was there with you in 2008 at NUH. So I invite you, Professor. Please kindly share your screen, and we can start the meeting.
Thank you very much, Mudit. I hope everyone can hear me and can see my screen.
1 minute, Professor. And show.
Are you seeing it or no? Not yet.
No, just wait. We are not seeing it. 1 minute. Okay. 1 minute. So
Mudit has to stop sharing his screen.
Okay. Yeah. Yeah, Professor, we are seeing it.
Oh, fantastic. Okay. Then I shall begin. Is that okay?
Yeah, you can.
Okay. All right. So first and foremost, good morning to everyone, and thank you very much for the invitation. It is certainly a privilege and an honor to be amongst esteemed colleagues of the Delhi Head and Neck Oncology Group. And thank you very much, Dr. Mudit, for the invitation. Certainly, Dr. Mudit was with us more than 10 years ago at the National University Hospital, and I've been in regular contact with him, and I know that he has been doing fantastic work since. I'm going to be talking on the management of recurrent nasopharyngeal carcinoma. And a lot of what I'm saying is based on the work that I do in Singapore. The nasopharyngeal carcinoma, NPC, the incidence has declined over the years. There's no question about that. But be that as it may, the Singapore Cancer Registry report in 2019 indicated that NPC remains a very common cancer in male patients from the age group of 30 to 39 and 40 to 49. In fact, it remains a common cancer in the age group of 50 to 59 males. So this has a significant social economic impact, given the fact that it occurs in a relatively younger age group compared to the common cancers of colorectal cancer or prostate cancer. Of course, in the Department of Otolaryngology, Head and Neck Surgery, NPC is the most common head and neck cancer that we deal with, followed by thyroid, oral cavity, and laryngeal cancers. At the National Cancer Institute of Singapore, which is a designated national cancer center in Singapore, for our head and neck tumor group, the NPC treatment protocols are as follows. Patients with stage 1 disease, we would advise RT alone. Patients with stage 2 and 3, we advise concurrent chemo RT. Occasionally for stage 2 patients, we may still advise only RT only. Patients with stage 4 disease, our protocol is adjuvant chemotherapy followed by concurrent chemo radiation. So using these protocols, the overall survival for these patients is approximately 70% at 5 years. We also know that the disease-specific survival correlates very well with the stage of disease, as indicated here by the black line, which represents stage 4 disease. You can see that there's a divergence between stage 4 and stage 1, 2, and 3. Similarly, the disease-specific survival is also correlated very well with end-stage disease. And here represented by the black line, N3 disease shows a significantly worse prognosis than patients with N1 and 2 disease. Recurrences are in the order of 20% to 25%. And in this particular cohort that we analyze, with a median follow-up of at least 5 years, the recurrence rate was measured at 21.7%. Most of the recurrences are distant in nature, but local and regional recurrences are uncommon and probably is anywhere between 5 to 8%. But when a local recurrence occurs, then our protocol for treatment at our cancer group is surgery. And if surgery is not possible, then often we think about using another modality such as radiation or even chemotherapy with or without radiation. Surgery is essentially nasopharyngectomy. There have been many approaches described for nasopharyngectomy. These approaches that I've listed here are the approaches that we use in the department here in Singapore. These include endoscopic, maxillotomy approach, the maxillary swing approach, which is, to me, the workhorse type of approach described by Professor William Wei. Transoral robotic approaches, which Dr. Raymond Chang will be explaining. And for certain types of tumors which extend beyond the nasopharynx, sometimes we may have to use a combination of approaches. Now I'm describing here a maxillotomy approach. This approach was the approach that I've utilized for quite a number of years. This was before the advent of the endoscopic approach, which seems to have superseded many open approaches for small volume disease. This is an approach which I use for small volume recurrences, RT1, RT2. And this approach involves using a lateral rhinotomy approach, much like how we would use it for open medial maxillectomy. And occasionally, we might have an alternative mid-facial degloving incision. This is an example of what I mean by a small volume disease, a very localized. This is a very favorable type of recurrence that was detected early in the nasopharynx, for which you can utilize any of the methods that you are comfortable with. This would be very ideal, certainly for nasopharyngectomy. And in this patient, as I've described, the lateral rhinotomy approach, the incision is made. I will then expose the maxilla and perform the osteotomies to essentially remove the medial wall of the maxilla, following which I'll then take out the posterior half of the nasal septum so that exposure into the nasopharynx is obtained. And I can see from eustachian cushion to eustachian cushion and therefore perform the resection of the entire nasopharynx, right down to the clivus if necessary, and in fact also I can take down the floor of the sphenoid sinus. And this approach allows me to also take the lateral pterygoid plates too. And so then I can remove the entire nasopharynx with a good margin, is what we would all like to achieve in all our surgical approaches. An alternative incision is the mid-facial degloving approach. The maxillary swing approach, which was described by Professor William Way more than 30 years ago, is a workhorse type of approach for nasopharyngectomy. This is an approach which is based on a very elegant principle of maintaining the vascularity of the osteocutaneous complex of the maxilla. Osteotomies are made, the maxilla is swung laterally to expose the nasopharynx. This approach affords a very good exposure. It allows a lot more instruments to get in and to help in the resection. This approach is also much more useful than all other approaches when it comes to trying to resect tumors that have extended into the parapharyngeal region, as well as being very close to the internal carotid artery. But a major feature of this is that because it is utilized largely to remove a much larger area of recurrence, very often the carotid artery is exposed, and therefore one of the basic principles is to cover the exposed carotid area, and very often we use a free flap, the anterolateral thigh flap. And so just for completeness sake, sometimes patients have a recurrence, and when we look at it, it extends beyond the nasopharynx, as in this patient, into the oropharynx, and we think that there's no other option for this patient. At least this was some time ago, and we thought that there was no other option and that surgically this may still be resectable, but we then have to use a combined approach, not just to resect the nasopharynx and perform the nasopharyngectomy, but we also, in this patient, we had to do a mandibular swing to approach the oropharynx. So combined approaches. And as you will know, there are other types of combined approaches. This is a combined approach to a tumor that has gone distally into the oropharynx. There can be tumors that extend superiorly into the cranium. And again, a colleague of ours, Professor Jimmy Chan in University of Hong Kong, has described, again, a very elegant approach where nonetheless it may be staged, but still a very good approach to resecting tumors that have invaded intracranially and for which surgical resection is still deemed possible. And he has described that, and he has a significant experience in that, and he has gained very admirable results from those approaches. So these are some of the combined approaches to deal with recurrence in the nasopharynx. Now, I looked at the series of patients where I only use a single type of approach, the maxillotomy approach, and these are, of course, necessarily all small volume disease, RT1 and RT2. Local control, in this instance, about 70%, which is consistent with most of the series that are reported, anywhere between 70 to 80%. However, I found also that 40% of these patients who had undergone nasopharyngectomy continues to have further recurrences. These recurrences are either in the local site or actually in the nodal metastases or at distant sites in the lungs or in the bones and so on. The 5-year disease-specific survival for this group of patients that are analyzed is not bad. It's 75%. It's 76.4% in this series. Certainly, more than 3/4 of these patients will attain a 5-year disease-specific survival. However, as I've alluded to, the 5-year disease-free survival is only approximately 40%. So how can we improve the outcomes of local recurrences? Well, one of the major tenets is that we have to remember that close surveillance, good examination, and high index of suspicion and biopsying areas which are suspicious will and still remains a very important key in detecting early recurrences. There have been a move, or there have been description of using the EBV DNA as a tool for detection of early tumors. But in our experience, we have found that it may not necessarily be so reliable because small volume recurrences or small volume tumors, the EBV DNA may not actually be that significantly raised. So one of the other areas that we are also looking into, in fact, this is a particular interest of Dr. Raymond Tang, is to look at the T2 or T3 tumors that have recurred. And we would want to consider using induction chemotherapy to shrink the size of the tumor before we move on to the nasopharyngectomy. And all of this is really to try to achieve the most important factor, or one of the important factors that govern good prognosis in nasopharyngectomy, and that is good, clear margins. So I just move on to regional recurrence. Essentially, nodal metastases can also occur after the primary treatment, and the treatment protocol at our cancer group is essentially surgery. The surgery is neck dissection. The majority of these neck dissections are going to be radical neck dissections. Occasionally, modified radical neck dissection is utilized. This is usually in the context of bilateral nodal metastases. You may ask, and you may certainly be familiar already, why a radical neck dissection is often the type of neck dissection we utilize. It's because most of the time, these tumors have extracapsular spread and occurs high up in the level 2 region. So not uncommonly, we see that it's very difficult to preserve the accessory nerve as well as internal jugular vein. And because of the nature of the extracapsular spread, we'll be taking a chance if we try to preserve the sternocleidomastoid muscle. So radical neck dissection, modified radical neck dissection, and not forgetting that in these patients, they have undergone chemo-RT, and sometimes wound healing is not as good. So there is also that consideration whenever we have to deal with nodal metastases, whether we use a pectoralis major flap. Not certainly all the time, but it's certainly something to think about whenever we have to deal with nodal metastases. And so I just wanted to bring perhaps describe to you that some time ago, I had actually, as a matter of default for patients who have undergone chemo-RT and then subsequently had nodal recurrences, I actually did a pectoralis major muscle flap where I rotated into the neck wound. These are patients where there was no skin loss, but nonetheless, after the neck dissection, I had put the pectoralis major flap into the neck wound in the belief that this group of patients will heal well and they do not break down and have that persistent problem of exposure of the carotid artery. Needless to say, in this group of patients that I performed the pectoralis major flap, none of them had any wound breakdowns, but the question remains, of course, whether this is beneficial, whether the addition of a pectoralis major flap to cover the neck wound when there's no significant loss of skin, whether it's necessarily better or not. But most of the time, when there's significant loss of skin, then we'd have to apply a pectoralis major flap because of the concerns for carotid blowout and also to cover the defect. So we analyzed a group of patients, 81 patients with 88 neck dissections. You can see the majority had radical neck dissection, and the majority had level 2 nodes, as I have alluded to, not surprising, but more importantly, 5 patients had level 1 lymph nodes. And so therefore, this really justifies why we would advocate considering removing all the nodal basins from level 1 to 5 into recurrent NPC in the neck. Now, generally, in this cohort of patients, we found that 60% of those who had undergone neck dissection went on to have further recurrences, and that majority of these further recurrences were at distant sites. Only 5% of the patients recurred in the neck post-neck dissection, and in fact, only 2.5% recurred in the operated neck. So the 5-year overall disease-specific, disease-free survivals unfortunately remain 50% or less, and therefore is suboptimal. But we also realize that in this group of patients who had undergone neck dissection, when they had originally N1 disease and then subsequently developed the nodal recurrence, the disease-free survival following the neck dissection to salvage the neck was 58%, compared with only 26% for the group who had N2, N3 disease. This indicates to us that neck dissection is a very effective modality in the treatment of nodal metastases. However, recurrences remain significant, and they are mainly distant sites. So the question is asked whether we should then apply further treatment to that subgroup of patients who are at a higher risk of developing distant metastases post-neck dissection. And so we've begun to consider applying chemotherapy in a certain group, those with original N2 or N3 disease who then recurred, and we did a neck dissection. So therefore, in summary, I would like to say that early T1, T2 recurrences have good local control, whichever approach that you use. Neck dissection is an effective modality of treatment for nodal recurrence, and that I certainly want to make a plug for close surveillance to be a major tenet as to how we can detect early recurrences, both in the nasopharynx as in the neck, as well as in the neck. Salvage for local recurrences remain suboptimal because of that subgroup that may still recur further. And there's certainly a lot of leeway for us to improve. And this is one of the major areas that we are looking into to improve the outcomes for these patients with local regional recurrences. So with that, I thank you. Sorry, Mudit, I think you are muted.
Thanks, Professor. Thanks for the wonderful presentation you had given. We would like to ask you, are there upfront any role for surgery, or it's only chemoradiation or radiation therapy, or its role of surgery is only in the salvage setting?
The answer to that is that as of now, the community and the recommendations remain as radiation for small volume disease. I certainly am not sure that patients with stage 4 or stage 3 disease that we want to consider surgery. I think the group, so based on your question, upfront surgery for treatment of NPC. So based on this question that you have, the group obviously that will be suitable for this will be the stage 1 group, meaning those with disease localized to the nasopharynx. It is possible, but the current recommendations and the convention remains that it is treated by radiation. The answer is that there is a group, and Professor Raymond Zhang will be very familiar. There is a group in Guangdong that is approaching this through surgery, as you mentioned. And it is possible because we have modalities of imaging right now that can help us identify whether it's really just truly localized to the nasopharynx. But yes, the answer it is possible, and this is also another area where we can save the RT for a later date.
Professor, other thing which you are finding that if you have a retropharyngeal node there, and how do we manage that? Because regional nodes in the neck, we can do salvage. But what about the retropharyngeal node if it's there? Have you come across
So-
conditions like that?
Yes, so retropharyngeal nodes, if it occurs, and sometimes we do see nothing but only the retropharyngeal node recurrence. There are a couple of problems with retropharyngeal nodes. First, you detect a retropharyngeal node, you cannot be sure that it's certainly recurrent cancer, because in the background where you don't have the actual recurrence in the nasopharynx, but you have an imaging of an enhancing node, not significant size, but nonetheless it is there, and perhaps it is slightly increasing in size, then you are caught in a situation where you have to consider dealing with it. In those instances, if it is in a good position, the approach can either be through a maxillary swing, and if not, an endoscopic approach is possible. And in fact, for Professor Raymond Zhang, it is entirely possible, depending on how high the retropharyngeal is or how inferior the retropharyngeal node is. You can also consider using the transoral robotic approach.
Right. So, Professor, any word about your research which you are doing on early screening of these patients?
So the answer is there's no question that screening is effective in picking up early cancers. In fact, of all more than 3/4, in fact, 80% of all the patients who had NPC picked up through screening had actually stage 1 or stage 2 disease. So the answer is beneficial. But the problem was that we had only screened those who are high risk. So the question is whether screening in the community where the risk is not as high may also have benefits. So we are currently, I'm now extending that screening to the community to see whether we can extend the benefit towards the community without high risk.
Okay, thanks, Professor. Any other questions in the chat box? Oh, okay. I think, Professor, I will request you if you could stay till the end, because we will be having a panel discussion. We would like to have your inputs regarding the managements which you people are day in and are doing, and we have only few cases we are dealing with. So I request you if you could be there for the panel discussion as well.
Sure, I'm more than happy. In fact, I'm looking forward to learning from you all. Thank you.
Okay. Thank you, Professor. Thanks a lot. So can you okay, unka stop sharing unka. Professor, can you stop sharing and mute all?
Sorry, I've stopped sharing already.
Yeah.
Okay.
Ready, sir. Dr. Mudit, should we start with our session? Dr. Mudit, not getting your voice.
We can begin the next session.
Involving us in this academic feast on this surgical aspect. Now we are going to hear about recurrent nasopharyngeal carcinoma. Say, or I can challenge the best speaker who can. Laskar, she is a professor at 2 decades in radiation oncology. She is doing lot of academic research, academic works in field of not head and neck cancer, esophagus cancer, brachytherapy, and recent and advanced techniques of radiotherapy. Without wasting time, I invite Professor Sarvani Laskar to start his talk.
Thank you very much. Good morning, everybody. I thank the organizers, Mudit, Munish, and Dr. Pandey for having me here. I'd like to start. Can you see my slides now?
Yes, ma'am. Yes, ma'am. You can start.
Yeah. Good morning. That was a very good beginning to this Sunday morning's topic. Management of nasopharyngeal cancers has always been close to my heart. And I chose to put 2 slides just now simply because I wanted to compare and contrast what we have in India versus what Singapore and Southern China see. So what we have in India is actually a very rare form of cancer. We do not, though India can be considered one of the leading countries as having a very high incidence of nasopharyngeal head and neck cancers, we really do not have nasopharyngeal cancers as commonly, and we only have a few pockets of high incidence. And this is a map from the ICMR.
Sorry, Dr. Sarvani, we are not able to see your
slides. Can you share your presentation?
Okay, I'll just do that. One minute. Let me just stop share.
Yeah.
Can you stop sharing the screen there?
Stop share. Stop share. Stop share. Yeah.
Yeah. So now I'll share my screen. Yes.
Yeah.
Can you see my screen now?
Yes, ma'am. We are seeing now.
Yeah. Okay. Okay. So is that all right? Yeah. So what we have, is this all right now? Munish, can you see my screen?
Yes, ma'am. We
Yes,
can see.
ma'am. Yes, ma'am.
Thank you so much. Okay, so what we have in India is actually very different from what Singapore or the rest of South China sees. We only have a few pockets of very high incidence in the northeastern parts of India, but in these areas, the incidence is as high as certain parts of southern China. And even in the TMH, where we see about 12,000 plus new cases of head and neck cancer, cancer of the nasopharynx at primary presentation actually constitutes only about 1.25% of the total burden of head and neck cancers. Now, coming to the problem that I have been asked to address, if you look at the problem with nasopharyngeal cancers and treatment, re-radiation is a real challenge in this situation because prior radiation dose that has been delivered is often close to the tolerance limit of the surrounding normal structures. Therefore, it becomes important for us to strike a balance between achieving local salvage and minimizing treatment toxicities. And most of the evidence that we have for the treatment or the retreatment of nasopharyngeal cancers actually comes from small retrospective series still very recently. Also, what we have seen over the last 2 decades almost is that there has been an evolution in surgical techniques, enabling better surgery to be done, especially for early recurrences. We, of course, have better imaging modalities, both anatomic and functional. We do have, at our behest, superior radiotherapy techniques, and because of the experience of the yesteryears, we have a better understanding of the biology. So if we were to detect a recurrence, would it be worth treating? So this is some evidence from a meta-analysis and a systematic review, which clearly shows that if we were to detect recurrences early, there is definitely a point in treating these cancers, and they enjoy good overall survival rates early on and even later. Of course, with advanced stages at recurrence, this does not remain the case. Now, having said that about treatment and its efficacy, it is very important in the retreatment setting, especially for recurrent nasopharyngeal cancers, to also look at morbidity. And of course, there is antecedent morbidity with effective treatment. What this systematic review actually tells us is that surgical therapy has similar overall survival and outcomes to re-radiation, but with decreased treatment-related morbidity and mortality, especially in the select cases. Both surgical and re-radiation for locally recurrent nasopharyngeal cancer have similar long-term survival. Surgical approaches may offer similar survival while avoiding treatment-associated morbidity and mortality. I will essentially be basing my talk on the guideline article published in the IJRUBP in about 2 years back. And they have tried to actually assimilate as well as give us consolidated guidelines about various aspects in the treatment of locally recurrent nasopharyngeal cancer. Now, one of the first things in the nature of the recurrence, whether it's local, of course, the outcomes are also a function of the nature. Should include a thorough assessment of onset of symptoms in this recurrent disease. Is mandatory. We would like to do both sets of imaging, that is a contrast enhanced MRI as well as a CT scan of the face and neck, a complete metastatic workup, preferably with 18 FDG PET CT scan. And of course, as Professor Lowe has already mentioned, the estimation of plasma EBV virus is less than well defined in this setting. The other things that need to be noted when we come across a recurrent nasopharyngeal cancer is that we definitely need to manage these patients in a multidisciplinary team, document the age, performance status, comorbidities, and patient preference, and also look at the disease-free interval of this patient. The details of the prior treatment that definitely need documentation are retrieval of the original radiotherapy plan to assess whether this is in the nature of a geographic miss or failure within a high dose volume, the fractionation that had been employed at the first treatment, whether it was conventional or hyperfractionation, the technique of radiotherapy used, the dose and the doses to the OARs and late toxicities that had already been incurred. Now, coming to the primary treatment, of course, as a general principle, the preferred option would be surgery, where the expertise is available and clear margins are likely to be achievable. And when they did this panel, there was 100% consensus with this aspect. Now, patients salvaged by surgery, re-radiotherapy may still have to be considered for positive resection margins. Again, there was good consensus to this statement also. Patients salvaged by surgery, re-radiotherapy should be considered for resection margins that are less than 2 to 5 millimeters with a moderate degree of agreeability between the panel of experts. Now, I'll bring you to this particular article or particular study that was published in 2021 in the Lancet Oncology, looking at the evidence for doing surgery versus re-radiotherapy. This was a multi-center open-label randomized phase 3 study accruing patients between 18 to 70 years of age, which accrued patients with locally recurrent nasopharyngeal cancer with tumors confined to the nasopharynx, posterior nares or nasal septum, superficial parapharyngeal space or base wall of the sphenoid. Patients were randomly assigned 1:1 to the two groups. The primary endpoint was overall survival at 3 years. And if you look at the distribution of the various characteristics across the two groups, they are more or less homogeneous and equally distributed. What they found was that in the 200 eligible patients who were randomly assigned between the two groups, at a median follow-up of 56 months, the 3-year overall survival was 85.8% in the endoscopic surgery group, whereas it was only 68% in the IMRT group. The common grade 3 or worse radiation-related late adverse event was pharyngeal mucositis and pharyngeal mucositis. 5 of the 99 patients who underwent endoscopic surgery and 20 of the 101 patients who underwent IMRT died due to late toxic effects specific to radiotherapy. So the trialists went on to say that endoscopic surgery significantly improved overall survival compared with IMRT in patients with resectable locally recurrent NPC. And this is the outcomes table. You can see very clearly that most of the factors are in favor of the patients who underwent endoscopic nasopharyngectomy. And this is a survival curve, the overall survival as well as the disease-free survival. And this is the toxicity. It seems to be that patients who underwent, though the toxicities are different between the two groups, the proportion of patients having toxicity as a sequel to treatment was somewhat lower in the endoscopic nasopharyngectomy group. Now, coming to other principles that the consensus guidelines do tell us, that patients who have a short latency of recurrence from completion of primary radiotherapy may really have to be considered with a lot of caution. Re-RT is not recommended, especially if the latency is less than or equal to 12 months, and especially so if it is less than or equal to 6 months. Patients with existing major radiotherapy toxicity as a result of the first course of radiotherapy, re-radiotherapy is definitely not recommended. And this is especially considering any form of brainstem, spinal cord, or optic chiasma toxicity, grade 3 or more toxicity at the temporal lobe, optic nerve, brachial plexus, soft tissue, or bone. Xerostomia, hearing, or endocrine toxicity is not a criteria for exclusion. Toxicity at the soft tissue or bone, patients could be excluded if they had more than grade 3 toxicity. Also, patients with bulky tumor, there is no reason to exclude them for re-radiotherapy based on tumor bulk alone. Now, these are the various dose prioritization and acceptance criteria suggested by the expert panel. And if you look at it, definitely what is important to decide upon accepting plans is the cumulative doses at the various critical structures. And this is especially for the brainstem, spinal cord, optic chiasm, optic nerve, the temporal lobes, carotid artery, the GTV recurrent, as well as the PTV, of course, come lower down in the order of priority. Now, coming to the issues of re-radiotherapy techniques and margins, one of the most important aspects in the radiotherapy planning for retreatment is, of course, multimodality image fusion for delineation of the target and OARs. The choice of radiotherapy is actually between protons and IMRT and VMAT. But we need to understand, because of the availability of protons being a challenge, patients would preferably and most often be treated with IMRT and VMAT, and there was 96% consensus about this fact. The principles of delineation of the recurrent CTV, that is the clinical target volume, was a geometric expansion, editing for air and skull base, and there seemed to be 96% consensus to this aspect. The margin for recurrent CTV are less than or equal to 5 millimeter expansion from the recurrent GTV to the recurrent CTV, but you need to keep in mind the aspect that several areas they could be abutting into the adjacent OARs, and the CTV expansion may have to be adjusted or modified in these regions, and typically posterior growth of the CTV. For the PTV, what was suggested was a 3 millimeter expansion or a 5 millimeter expansion, depending on the size and volume of the CTV. But most often posteriorly, this PTV would have to be edited and kept to a minimum of 2 to 3 millimeters with daily imaging. Now, why is it important to deliver re-radiotherapy with high precision techniques? Essentially, to provide superior coverage and better sparing of the surrounding normal structures. This is one of the studies commenting on the outcomes with the use of IMRT, and which could restrict the grade 3-4 toxicities. But remember, toxicity, in addition to disease recurrence, is a competing risk in these patients, and the most common late toxicities seen across series is, of course, massive hemorrhage. And if you look at this, this is the incidence of late toxicities, grade 3, 4, and 5 across various sites like mucosal necrosis, headache, cranial nerve palsies, trismus, hearing deficits, neck fibrosis. And also the various prognostic factors that emerge from this study, at least, are the use of systemic therapy, the time to recurrence, and the use or no use of brachytherapy. Now, this is a table looking at various series that have commented on the use of IMRT, and you will realize that various stages of recurrent disease have been treated. The median follow-up essentially is also a function of this, and so are the outcomes, which we see very clearly are a reflection of the disease stage at recurrence. Now, there have been various prognostic models that have been suggested for recurrent disease and the impact of treatment on these patients. One of these series reported by Tian actually considers 251 patients who were treated for locally recurrent nasopharyngeal cancers. They arrived at the various prognostic factors, that is the stage at recurrence, synchronous nodal recurrence, the volume of the GTV, use of chemotherapy, re-radiation doses, various risk groups based on the scores that they gave based on the hazard ratios, and they came up with actually and the high risk group based on the scores based on the nomogram or a clear demarcation between the three groups that emerged after assigning them scores based on the various prognostic factors. Now, the other technique of delivering radiotherapy, and which is quite a buzzword today, especially in our country, is the use of stereotactic body radiotherapy or re-radiotherapy. Compared with single fraction, definitely in the recurrent setting, at least experience suggests, and whatever there is in literature suggests, that fractionated stereotactic radiotherapy would be the way to go. This is one of the series that is that talks about the same, and the complete response rate was about 66% for group 1, that is the group that had a relapse within 6 months of radiotherapy, or the recurrent disease group, which was group 2, which was a relapse beyond 6 months. And you can see that there doesn't seem to be a difference, but provided these patients were selected very carefully, and the independent factors for outcomes, for poorer outcomes for recurrent disease and large tumor volume. Now, with persistent disease seem to be doing better than recurrent disease, persistent disease being disease that was within 6 months of the primary treatment, and recurrent disease, of course, beyond 6 months. Similarly, if you look at the disease peak, the specific survival, the volume of disease again was very important in predicting the outcomes following stereotactic radiotherapy. These are various other series that have reported on the use of stereotactic radiosurgery versus fractionated radiotherapy. And again, what you should realize here that in the recurrent setting, the outcomes are poorer than that in the persistent disease setting. But again, we have to remember as you go through these papers that these are all a function of the volume treated, the time to recurrence, as well as the doses that could be delivered. Not only are the outcomes a function of this, but so are the major complications. This is again a comparative table showing a difference in the outcomes between the use of various techniques of radiotherapy, that is 2D radiotherapy to stereotactic radiotherapy to IMRT, and we realize that not only local outcomes are improving, but so are the overall complications reducing. The next new kid on the block, of course, is the use of proton therapy. In the recurrent setting, the experience is not so large, but whatever experience is available suggests the fact that probably it would be able to reduce the incidence of acute as well as late toxicity with the use of proton beam therapy. Carbon ions also have been similarly utilized, and delivering an intensity modulated carbon therapy dose of about 50 to 66 gray equivalent, what we could achieve is good dose displays, which could actually give us more conformal dose, restrict the dose to the surrounding structures, and also acceptable toxicity with very promising disease outcomes at 1 year. The other modality of radiotherapy that has been used is brachytherapy, though its use today is receding. But of course, it can be used in well circumscribed lesions that are not very deep or thick. And we could use doses depending upon the situation, whether it was persistent disease or recurrent disease. And these are series that have utilized brachytherapy, but brachytherapy techniques, the use of brachytherapy is actually receding that we have in our armamentarium. Vaccination, what has been suggested is that to aim at cure, we need to deliver doses closer to 62-66 gray in either conventional fractionation or altered hyperfractionation. And there are definite outcomes in literature that have suggested that doses of more than 60 gray actually result in better outcomes than lower doses. This is again a recently published study which looks at hyperfractionation radiotherapy with standard fractionation for the treatment of locally advanced recurrent nasopharyngeal cancer. And what this study clearly tells us that in the 144 patients who were selected in southern China for this kind of treatment and randomly assigned to hyperfractionated radiotherapy, a dose of 65 gray in 54 fractions versus 60 gray in 30 fractions, irradiating only the grossly involved tumor or the lymph nodal regions without elective volumes. At a median follow-up of 45 months, the outcomes were definitely in favor of hyperfractionated radiotherapy, and this was true even for the toxicities. And this is the kind of difference that was seen in this group of patients. The other thing, of course, is do we add systemic therapy to radiotherapy? It has been proposed that perhaps for higher stage recurrences, we would need the addition of systemic therapy. It could be induction with or without concurrent. The choice of cytotoxic drugs, whenever feasible, should be cisplatinum. For patients with more than 6-month interval from previous radiation therapy, plus minus concurrent chemotherapy, and with good renal function, in the concurrent phase, cisplatinum would be the preferred drug, and in the induction phase, also cytotoxic drug combination using cisplatinum. There was no evidence to suggest that the addition of immunotherapy, at least as of now, is beneficial. Now, these are outcomes from another study that has used concurrent chemoradiotherapy in the recurrent setting, and we see very clearly that there is definitely a favor for the use of concurrent chemotherapy, but of course, at the cost of higher acute and late toxicities. Now, this is a little experience with the use of retreatment with IMRT in patients who had failed. This is an older series which we have not yet published. We treated 22 recurrent nasopharyngeal cancers, and most of them were advanced stage with or without nodal involvement. And what we realized was that the median time to re-RT in our case was about 33 months. We tried to deliver a median dose of about 60 gray with a median follow-up, which seems short, 15 months only. We had a 1-year survival and disease-specific survival of about 66.7% and 67%. And at 2 years, it was 50% and 38 and almost 39%. We, of course, have recent patients who've been treated, and we are yet to analyze the results of those patients. What about regional recurrences? A word before I complete. Incidence of isolated failure in the neck following combination is very low. However, for those patients with advanced nodal disease at presentation, it may be as high as 33%. They may be managed with the second course of radiotherapy, but this results in a lot of unwanted toxicity, and it is also associated with poorer response and increased complications and morbidity. With surgical salvage, however, the reported 5-year tumor control rate in the neck is as high as 66%, and the 5-year actual survival as 38%. In one of the series reported from the William Y group, what we see clearly is that when there is residual disease, a lot of this disease is viable and it may have extracapsular extension. Herein, the role of radiation therapy is essentially for the use of afterloading brachytherapy in the perioperative period, which can enhance the regional control. I'd like to end with a case capsule. This is a 32-year-old girl, a lady who presented to us and was diagnosed as having a poorly differentiated nasopharyngeal cancer. It was a proliferative growth in the left nasopharynx. The slides and blocks were reviewed at TMH, and it was an undifferentiated nasopharyngeal cancer. When we did the plasma EBV titers, they were not detectable. Other ancillary tests were done and they were within normal limits. She had a large growth in the nasopharynx on the left side, crossing the midline, laterally involving the left pterygoid plate and displacing the pterygoid muscle. Posteriorly, the left longus colli was involved, superiorly till the foramen oval. Pterygopalatine and pterygomaxillary fissures were uninvolved, and bilateral enlarged conglomerate lymph nodes from level 2 to 5. This was the appearance of the disease at presentation. You can see that there is a lot of lateral and posterior extension of the disease, and also bilateral large lymph nodes. As part of the institutional policy, we also did a metastatic workup, and there was disease that confirmed that was seen on the MRI. In addition, of course, there was no metastatic disease that we saw in this patient. So she was a T4N2M0. So this is what we do in our patients, planned with neoadjuvant chemotherapy followed by chemoradiotherapy. The usual induction regime is 3 cycles of DCF. She had a partial response with an interval decrease in both the primary as well as the bilateral cervical lymph nodes. So we went ahead with concurrent chemoradiotherapy, and our usual schedule is 66 gray in 30 fractions to the high risk. And we usually do a low risk without an intermediate risk, and that was 54 gray in 30 fractions, along with concurrent chemotherapy. And these are the RT isodose washes. I would request you to look at these carefully. And this is what we achieved in the patient. This was the target coverage. These were the doses to the OARs. When I started by saying that when we start off and we give the first course of radiotherapy itself, our OAR doses are near tolerance. Okay, doesn't matter, but they're still within tolerance and within acceptable limits. Radiotherapy conclusion, patient completed treatment without any gaps, tolerated it well, and of course developed grade 1 reactions at the skin, mucositis and dysphagia. And she came on follow-up after 3 months when we assessed the response, and we found a complete metabolic response at the site of primary as well as regional lymph nodes. However, unfortunately for her and for us, she presented about 2 years and 11 months later with fullness at the left upper neck and the left ear. She felt a sensation of fullness. And when we examined her on D&E, there was nothing, but we did the PET scan, and the PET scan showed us a disease recurrence at the local site as well as at the local size. And then we did an MRI. The MRI also confirmed the findings. We did a biopsy. It was a recurrent nasopharyngeal cancer. And then what happened was that we again discussed this patient in the skull-based clinic, not considered for surgery due to proximity and indistinct planes with the carotids on the ipsilateral side, and hence she was planned for concurrent chemoradiotherapy. She went on to receiving 64 gray in 32 fractions. And this was the kind of radiotherapy planning and image fusion, contouring and radiotherapy planning that we did. And we could deliver 64 gray in 32 fractions with concurrent chemotherapy without any interruptions. And this was the kind of target coverage we achieved. This was the doses to the adjacent OARs in the second course of radiotherapy. She completed the treatment again without any gaps. And the present status is that she was started again on maintenance capecitabine but had poor tolerance. She has not come back on follow-up, but she's on a telephonic follow-up, has done her scans locally. She remains NED so far and has not suffered from any significant toxicity, late toxicity of the treatment so far. I'd like to conclude by saying that patient selection is the cornerstone to successful outcome. Most still present at advanced stages at recurrence. It is essential for us to ascertain the details of prior radiotherapy, optimal treatment of localized recurrence, especially since they present to us in advanced stages. We do tend to use combined modality management whenever feasible and when the patient is going to tolerate it. The issues with radiotherapy, of course, are the disease-free interval, the target volumes, the OAR doses, fractionation schedules, the technique. And of course, we have to be able to deliver doses of above 60 gray to be effective. And attention to supportive care and quality of life issues are very important with diligent documentation and reporting. This is a schematic diagram which shows the algorithm for the management of recurrent nasopharyngeal cancers. And I'd like to end my talk here and thank you for a patient hearing.
Thank you, Dr. Sarbani. Nice overview. And as always, of course, You have already covered all the possible questions which we were thinking to ask you. But nevertheless, I just wanted to ask you how many percentage of patient at KMH, at your my biggest center, they are undergoing surgery
You
for
know,
nasopharynx?
yeah, thank you for that question. We know and we also have evidence to say that surgery is good. Surgery should be the preferred modality for our early stage recurrences. But unfortunately for us, very few of the recurrences actually present in early stages. And even if you look at literature, we don't have literature, unfortunately, from our country, but we realize even worldwide, the incidence of patients presenting with early stage cancers are very low. So if you look at the number of, but fortunately for us, we really do not see too many local failures either. Our publication on the same has shown that, we have local control rates that are comparable with the rest of the world. So we hardly see, if we treat about 60 nasopharyngeal, 40 to 60 nasopharyngeal cancers every year. And out of that, we would see about 2 to 4 local recurrences and 1 or 2 regional recurrences at best. Of the 2 to 4 local recurrences that we may see in a year, maybe out of it, 1 at best would be amenable to surgery. The rest will not be amenable to surgery. And that is why then we have to go the non-surgical way, which would usually be a combination of induction, concurrent chemotherapy. That would be the most commonly utilized regime that we would use.
So that means out of recurrences, about 50% of the patient, they are going for surgery.
No, they are not. So then that's what I'm trying to tell you is it doesn't happen. 50%, what I meant is that, okay, sorry, I think I got my figures wrong. So what I would say is if I were to say see about 3 to 4 recurrences in a year, at best 1 would go for surgery. That is only about 25% may come up for surgery, and sometimes not even that much.
So my question,
yes.
Yeah, sorry. Yeah, please, you go ahead.
No, so the thing is that what happens in most of our patients, as I have seen them, in most patients, the reason for refusing surgery is usually, whatever I can remember off my head, is usually the posterolateral extent of disease.
So those patients who are undergoing surgery, how many percentage of the patients they require adjuvant radiation plus minus chemo?
Adjuvant radiation, whatever has been done, whoever has undergone surgery, very often we have not given because they've done a gross total resection, by which it means that at least the margins that are reported on pathology are negative. But yes, we do not get the classical 5 millimeter wide margins. We don't get that. But again, for reasons of morbidity, we have very often not given adjuvant radiotherapy to these patients if their margins on surgery have been negative and at least more than 1 millimeter away.
Okay. So I think there are 1 or 2 questions in the chat box also. You said that the ideal time to re-radiate is 1 year, no?
Yes.
1 year plus?
Yes.
1 year plus. So what I wanted to ask you, see, you are in the tertiary cancer center, you are sitting there, and many at times you get patients from outside after the recurrence. Then how do you manage those patients? Because many times you don't get the radiation details.
That's a very good question, Manish, and I thank you for bringing up this point. Besides nasopharynx, even for other non-nasopharyngeal head and neck cancers, we very often do not get the details of prior radiotherapy. So how we use the factors that we have at hand to dictate our decision are 2 or 3 things. We look at the disease-free interval. We look at the sequelae of prior radiotherapy. And as far as the radiotherapy details are concerned, we try and get whatever we can. But if we cannot, we consider them as the worst case scenario. So if you ask me, I would consider that the brainstem has received the full 54 gray. The spinal cord has received the full 46 gray. If I am considering that patient for re-radiotherapy. So I always would consider the worst case scenario, especially in terms of the doses to the OARs, so that the second time round we can be safe with them and we could then achieve acceptable cumulative doses, especially at the critical structures of brainstem, spinal cord, optic chiasma, and optic nerves.
Last question, because I think somebody has in the chat box is there. What is the limitation of doing brachytherapy? Because that is a good modality. Why we are not doing brachy?
So the reason we are not doing brachytherapy very often nowadays, especially in the primary setting, we are not doing it because we've got good techniques of external beam radiotherapy and it allows us to give the full doses that we need to give. Now, the biggest problem with doing brachytherapy for the primary in the nasopharynx is the dose to the surrounding structures, especially the palate. So if you have very thick lesions that are more than 10 millimeters thick, it is preferable, especially towards the palate, because what happens is the nasopharyngeal mucosa for any kind of brachytherapy, unless you do interstitial intraoperative brachytherapy for the applicators that you have, that is the Rotterdam applicator as well as the balloon applicators from Electa, what happens is the dose to the nasopharyngeal mucosa is almost the same as the dose that goes to the palatal mucosa. And if you remember the 2D things which have been extrapolated to the CT also from Rotterdam, you realize that the dose, you will really have to play with your optimization to see that your nasopharyngeal mucosa receives a higher dose than the palate, which is most often not possible. And with that, what happens is you get toxicity with the palate. That means fenestrums. Usually you get holes in the palate, you get toxicities, regurgitation. So one of the biggest things that actually precludes the use of brachytherapy in the recurrent setting is the volume of disease, the local extent of disease, and lesions being more than 10 millimeters thick, which means the morbidity would be higher if you were to cover these lesions adequately with brachytherapy.
And last quick answer, because whenever we talk about the re-radiation, most of our surgeons they are worried about ORM. So what is your take on this?
I can tell you this much, that in our whole non-nasopharyngeal re-radiotherapy setting, our incidence of ORN is less than 10%. And that too, because our re-radiotherapy setting in the non-nasopharynx is mostly oral cavity, again, let me tell you. Despite that, the incidence of ORN is very low. And in the nasopharynx, I really would not be concerned about ORN. I would be more concerned about carotid doses, about doses to the temporal lobes, and about doses to, of course, the other critical structures in its vicinity. In nasopharynx, definitely ORN is not something that I would worry about. I would be worried more about the temporal lobes and the carotid doses, in addition, of course, the doses to the other critical structures.
Thank you, Dr. Sarvani. Thank you very much. And I'm now handing over to Dr. Mudit. Dr. Mudit, please. Thank you. Dr. Mudit. Hello, Dr. Mudit.
Hello.
Dr. Mudit, please.
Yeah. Hello.
Yes, Dr.
Hello.
Mudit, please. Yeah. Dr. Mudit.
Video also on. Yeah. We will now begin our next session, and we invite the chairperson for the next session.
Moving ahead, the next session is a talk on a role of robotic nasopharyngectomy by Professor Raymond Sang. And to chair this session, we call upon Dr. Rajiv Sharan, a senior consultant and HOD, HCG Cancer Center, Kolkata, and Dr. Vipin Arora, a professor, Department of ENT and Head and Neck Surgery, UCMS, Delhi.
Dr. Rajiv. Dr. Rajiv Sharan? Hello? Dr. Vipin?
Yes. Yes, Mudit, I'm here.
Yeah, Vipin. Yeah, take over the session, please.
Okay. Dr. Rajiv, can you hear me? Should I introduce a speaker?
Yeah, please go ahead.
It is indeed a pleasure for me to introduce the speaker, Dr. Raymond Sang. He's Associate Professor of Otolaryngology at Yong Lu Lin School of Medicine, National University of Singapore. And he's a senior consultant in the department. He's a senior consultant in the Department of Otolaryngology and Head and Neck Surgery, National University Hospital at Singapore. His specialty is head and neck surgery, and he has special interest in robotic and endoscopic head and neck surgery, and particularly for surgery for the recurrent nasopharyngeal carcinomas. Dr. Sang graduated from Chinese University of Hong Kong in the year 1994 and received his training in otolaryngology from Prince of Wales Hospital, Chinese University of Hong Kong. He obtained special qualification in otolaryngology, and he's a fellow of Royal College of Surgeons of Edinburgh in 2001, and then subspecialized in the field of head and neck surgery. Dr. Sang received his training in robotic head and neck surgery from University of Pennsylvania and University of Texas at MD Anderson Cancer Center. And Dr. Sang was part of the team that performed the first clinical trial on the next generation flexible robot application in transoral head and neck surgery in 2017. He has more than 100 peer-reviewed publications, and he's the president of Hong Kong Head and Neck Society, and he's the chairman of Head and Neck Specialty Board of the Hong Kong College of Otolaryngologists. With this introduction, I request Dr. Sang, and he'll be talking on robotic nasopharyngectomy. Dr. Sang.
Thank you, Chairman. You can all hear me. I would like to thank Dr. Mudit from inviting me to give a talk. I'm happy to see all my Indian friends, although we're online. Hopefully we can meet again soon. Let me just share my PowerPoint. Yes. To me, but since the hospital, I'm really grateful from everyone. I need to work on my same interest, which is so greetings from Hong Kong. You can find, and the majority of us are of nasopharynx cancer. Now, just have a disclosure. Intuitive Surgical, the robot company for 2013 to 2017. So when we look in NPC, I mean, there is one paper that we look into Hong Kong back in. This paper was published in 2019, which looked in the data of the past 10 years in all the NPC patients treated in the public service in Hong Kong. And we found that the local failures is around 14.2%, which is mostly infield, around 272 patients. Now, some of the causes are, of course, due to in the T4 cancers where we cannot generate a very high dose, but others we still find some infield failures in a small primaries. Now, when we look at the prognostic factor for retreatment of this group of local failures, we find that old age and advanced T staging were advanced recurrent T staging was the adverse prognostic factor. So mostly the T4s, when they recur, they're usually also a T4. So mostly if they're originally intracranial, they recur, they tend to be more intracranial. Whereas surgery and is associated with a favorable survival. And we find that for surgical patients, if you have achieved an R0 resection, it's much better survival than an R1 resection, meaning that if you have a microscopic positive margin. And for a lot of these R1 resections, we also give adjuvant radiation. We found that adjuvant radiation after an R1 resection really do not improve local control. So most importantly is to achieve an R0 resection. This is the graph showing that patients who have an RT1, the blue line, do much better than the rest, and patients who treated surgically tends to be a much better survival. Now, Professor William Wei, which is my mentor and also the previous head of department in the head and neck team in the University of Hong Kong, where he invented the maxillary string procedure. At 2012, he kind of retired from academic practice, and he summarized his case series of 246 procedures, which showing that with an open nasopharyngectomy, we achieve a local control of around 74% and a 5-year disease-free survival of 56%. So it's sort of around 70 to 80% local control for surgically treated recurrent nasopharynx cancer. Now, Dr. Zabrini has already mentioned this paper, which is actually one of the few papers in head and neck surgery that trying to compare a surgical treated with radiation treated for diseases. And we show that surgery has a better overall survival and also complication, I mean toxicity compared to radiation for early stage RT1-2 recurrent nasopharyngeal carcinoma. So when we talk about the nasopharynx, the problem with the surgery in nasopharynx is the nasopharynx is really in the middle of the skull. So is actually any approach to it will probably need to transgress some bones, except you do a transpalatal procedure. So whether you come from the lateral, as in a lateral skull-based approach, or come from the front as a maxillary string approach, you still need to cut through some bones. Technique. This is first described by the Japanese in cases using endoscopic technique. I know later the endoscopic technique and robotic technique are actually the same. Use the amount of normal tissue when we damage. When we talk about open nasopharyngectomy, which I still perform quite a bit, obtain the exposure. But once you have the exposure, you really have a loss. In terms of endoscopic nasopharyngectomy, the visualization is excellent with it. But unfortunately, the instruments we do in a very narrow field. So now we have the robot. Tissue manipulation. When we have open approach, we have poor visualization. We have endoscopic approach. We have good visualization with poor instrumentation. Can the robot give us the best of both worlds? What I think is the current generation of robot, not there yet. Hopefully in the future, we still have that, but there are still a role in the robot. Now, we all know about the advantage of a robot. Actually, the main advantage of a robot, I ask you to look at this video, it's the degree of movement that we have and the kind of dexterity that we have with which we have to sacrifice in the endoscopic techniques. So, but then when we do a robot, we have to decide whether should we go transnasally or transorally. Now, transnasal deployment, unfortunately, we need to remove a lot of bone. I'll show you in a few slides. Which at first, I mean, there's a cadaveric dissection experiment by Yonsei and also another doctor in Singapore, Dr. Heng Yan Tay, which in Singapore General Hospital, we apply this technique. So when you do the transnasal approach, you put the scope through one nostril and the robotic arms either through the maxilla from a canine fossa approach, or you do it one arm through the nose and the other arm through the maxilla. So you have to remove all the bones in between, including the nasal septum. So what you need to do is you need to do a bilateral medial maxillectomy and also a septectomy, move the septum away in order you can gain access to the nasopharynx with the robot. Now, there's still quite a bit of bone removal, I mean, which is more than what we need for an endoscopic technique. So I would say I'm still not my favorite, and also the pterygoid plates will be a limit for your lateral movements. So I actually adopt the transoral approach. We have to somehow deal with the soft palate, and when we deal with the soft palate, we want to preserve the function of the soft palate because that's important for swallowing and to prevent velopharyngeal incompetence. So the first described cadaveric experiment is by a group in Ohio, Professor Osler, and they did a palatal split approach where they split the palate, and soon after that, Professor Wei did the first clinical case using a palatal split approach back in 2011. Now, 2010, actually, the surgery was done in 2010. So, I started off with this approach, but before that, I want to talk about the indication for robotic nasopharyngectomy. It's actually very similar to indication for endoscopic nasopharyngectomy. Basically, you want small tumors. Tumors are a bit far away from the internal carotid artery. I would choose anything more than 5 millimeter. Now, for nasopharyngectomy, we don't get centimeter margins. The nasopharynx is very small. So most of the time, 5 millimeter is adequate margin. So we want to be a bit far away so that we don't accidentally damage the internal carotid artery. There shouldn't be a lot of clivus invasion because if you have gross clival marrow invasion, I don't think a surgical approach is actually going to completely remove all the tumor cells which will be infiltrating into the bone, unless you remove the whole clival bone, which is impossible because then you will expose the dura, the brainstem to the atmosphere. Now, the tumor cannot be too lateral, so normally I would say limit by the lateral pterygoid plates, because if it's more lateral, your robotic instruments have a hard time reaching it. For those laterally extended tumors into the parapharyngeal space, beyond the lateral pterygoid plates, I still will use a maxillary swing, open maxillary swing approach. And tumors who invaded anteriorly to the pterygomaxillary fissure, the robotic instrument is not going to reach it transorally. I would rather use an endoscopic approach, which I still use for selected cases, although I prefer the robot because of the simplicity of the operation. Now, for tumors who abut the ICA, like this is quite a bulky tumor with abuts on the ICA, I do not use a robotic approach. I would also probably shy away from an endoscopic approach because such a bulky tumor, unless you take it out in a piecemeal one, on-block resection will be quite difficult because the tumor will be blocking your visualization of the internal carotid artery and accidental injury can happen. I still prefer an open approach where I can find the proximal and distal control of the internal carotid artery and then take the whole tumor out. So for some patients who have a trismus after surgery, after radiation, I do not do an endoscopic robotic approach because I cannot place a robot. So these patients, I'll use an endoscopic approach, and you should have no velopharyngeal incompetence, and the dentition should be good because if you use a very poor dentition, opening the mouth with the mouth gap can actually damage the teeth. So those patients, I would choose an endoscopic approach. So I'm going to show how we do a palatal split, which is some easier technique, but I'm less and less doing it. We split the palate from the midline all the way to the hard palate, and then I retract the palate laterally with the stay stitches, use a 0 degrees telescope, and then close it in 3 layers. So this is after splitting the palate. You can see now you can actually approach with a headlight and some open instruments, but the visualization tends to be poor because your hands is going to block the view. So with the robot, you have a much better visualization, and the robotic arm with the wristed instruments give you a much easier dissection. And then afterwards, you have to close this palate in a 3-layer. The nasopharynx mucosa, the muscle layer, and then the soft palate oral cavity mucosal layer. And the patient needs to be put on tube feeding for a week or so to let the palate heal to prevent the fistula formation. So this is after closing the palate, and afterwards closing it, you can see they put the patient on tube feeding because allow them to eat, to swallow. These stitches can tear and end up with a palatal fistula. So this is a palatal split nasopharyngectomy video. So this is a small recurrent tumor just posterior to the eustachian tube cushion. After splitting the palate, you can see with the 0-degree scope, you can see the eustachian tube, the fossa rosumella, the recurrent tumor, and I try to mark around 5 millimeter to a centimeter margin with my instruments. So you can see the good thing about the robot is a very stable platform. Although I know a very experienced group and endoscopic technique will be able to achieve the same resection. And then after marking, I use the technique what Professor Chen Mingyun from Guangzhou described, wrapping the dumpling. So you consider this is the dumpling skin, and this is the content of the dumpling. You just wrap everything around it. So you dissect from all 4 sides towards the center, which is your tumor, recurrent tumor. So with the robot, I can have traction and counter-traction. And my system will also assist me to do a bit of traction with the suction. And then dissect from inferior to superior. From the mouth, you can see the preveral muscle. And this is on the top from the clivus. I tend to preserve the preveral muscle unless the tumor has invaded it, because that will actually reduce the amount of exposed bone and the risk of radiation necrosis post-op. So I've wrapped the dumpling. You can see the recurrent tumor in the middle. I've wrapped the dumpling and the tumor coming out. So this is the eustachian tube, where is the deep margin, and abstain frozen section from there. The internal carotid artery will be lateral to the eustachian tube. And then I'll cover the area with a nasoseptal flap. But nowadays, more and more, especially the new XI robot, Da Vinci XI, I tend to do this palatal suspension technique. Instead of splitting the whole palate, I just make 2 incisions at the upper pole of the tonsil, similar to what they call the layup procedure for sleep surgery. I actually learned this from the sleep surgeon when we cut just the anterior and posterior pillar at the soft palate, and then retract the palate forward. And using a 30-degree scope, we can actually approach the tumor in a curved way. So this is the case with a recurrent NPC, a small RT1 recurrence around a 12 millimeter size in tumor, which is not invading the skull base and not close to the internal carotid artery. You can see it's actually in the fossa and far away from the carotid. It's only a fossa recurrence. And I'll use the palatal suspension technique, which is my workhorse now, mainstay. So first, I will mark the lesion with an endoscope. So this is the contralateral side. So I see that because from below, the view of here is very tangential. So I'd rather mark it instead to prevent a positive margin. I mark the medial and the superior margins with an endoscope, and then incising the palate with a Dingman retractor. And then marking the 2 palatal incisions, I make the 2 incisions on the anterior and posterior pillar of the tonsil. And then using stay stitches, you can pull the soft palate forward. And then with the 30-degree scope come from below, this is the view you can see. So these are the margins that I marked. And then the inferior margins are better seen with an endoscope. So this is the recurrent tumor here. So with the robot, so from below, I can continue marking the inferior margins. And the lateral margin will be on the pterygoid plate. So I detach the pterygoid plate from the mucosa from the pterygoid plate and the pharyngobasilar fascia. And using a Da Vinci XI, you can see there's a parapharyngeal space, and that's a ascending pharyngeal artery, which unfortunately I accidentally damage it and have to stop it. But with the XI, you can cauterize it. And I know the tumor hasn't invaded, so I take a cup of parapharyngeal fat that should be enough for my lateral margin. And coming from inferior, incise the pharyngeal constrictors, and then you meet the muscles of the eustachian tube, the tensor veli palatini and the levator palatini muscles, and dissect from inferior to superior, leaving a bit of preveral muscle on the bone so that I don't have to expose too much bone. So coming from inferior to superior, and then this is lateral, coming from the top, wrapping the dumpling, similar. At the top there is no muscle, so it will be the clivus bone. So this is the eustachian tube. We're going to divide the eustachian tube, hug close to it, because otherwise you go lateral, you hit the carotid, and divide it flush at the skull base. And then I remove the tumor out. And this is the defect. So with this, I can obtain fluid section margins with the robot. You can see some pulsation. Actually, that was the carotid artery deep in the parapharyngeal space, still covered by some parapharyngeal fat. And this defect, I'll use a nasoseptal flap now routinely to cover it, because that way, now this is the radioseptal flap, harvest endoscopically while I wait for my fluid section margins, and then insert it with tissue glue, and also using a urinary catheter balloon to hold it in place. And suture the palatal incision. So this is a specimen, around 2 centimeter times 2 centimeter defect, which is so post up 2 weeks. I will allow the patient to eat the next day, but the patient sometimes in pain. So after on soft diet, it's more like a sleep surgery, the pain. And around 10 weeks, you can see a little bit of scarring, but the palatal function is all preserved because I haven't divided the tensor palatine muscle on the one side, so the function is preserved. So just quickly share my experience before I left University of Hong Kong and moving over to Singapore. I concluded my experience of 31 patients who are recurrent NPCs who have more than 2-year follow-up. Actually, I probably now up to date, I've done around 45 to 50 patients altogether. The 29 cases are using the old robot and 2 cases are using the new robot. And this has been published in 2002, last year in Head Neck, about this is the data. So the majority are male, of course, and median age is 55, although I have the eldest is 85, the youngest 29. The median recurrence interval is actually around 4 years, but some are earlier, 8 months, and the longest is more than 8 years. We do have late recurrence. In Hong Kong, where there's a public system and it's a small place, patients do have regular follow-ups. So we are able to pick up these recurrence in early. So the majority of the approach are the palatal split, but now after that, I switched to a palatal suspension. Now the majority of my cases are palatal suspension. There's an old technique of lateral palatal flap, which now I tend to not use it because of the palatal dysfunction, and with the new robot, you don't need that. So I'm not going to describe it in this talk. There are no 30-day mortality, but I have one serious adverse event, which is not related to surgery, but more related to the tongue. So the patient had severe tongue swelling after the operation, and the patient developed hypoxic upper area obstruction in the recovery room 20 minutes after extubation and suffered from hypoxic brain damage. So the thing is, the tongue was compressed for hours, and you can develop reperfusion injury after you release the tongue gap. So nowadays, for all my patients who are a robot, I after removal of the Dingman retractor, I leave the patient intubated for 30 minutes and then reassess whether there's any tongue swelling. If there's any tongue swelling, I send the patient to ICU and only extubate the next day. So the median operative time is around 4 hours. That would include docking and everything. The median is from 97 minutes to 500 minutes. That the 500 minutes is the patient who actually already included a selective neck dissection. So normally it's around 3 to 4 hours operation if we just do a nasopharyngectomy without a neck dissection. So the blood loss median blood loss is around 200 mils, except one patient who has bleeding from the pterygoid plexus, venous bleeding, which I was not able to stop and finally need to do a nasal pack, do a packing, a postnasal and anterior nasal packing to stop it. There's no internal carotid artery injury, although I have 2 patients who developed carotid blowout because of the exposed artery after the operation. The 5-year overall survival is around 52%. Disease-specific survival is 59%. The local control is 82%. So the majority were distant failures. The majority of the are due to distant metastases. So when we look at the local control, compare a positive to a negative margin, you can see there's a big difference. Those with positive margins tend to be much bigger, much better compared to those with a positive microscopic margin, even though I would usually add adjacent radiation for these positive margins. So the advantage of a robotic nasopharyngectomy compared to open resection is there's no facial scar, much less pain because there's no osteotomy, much less blood loss, and no need for a tracheostomy, and usually a shorter hospital stay. compared to endoscopic resection, the benefit is less. I mean, except that the dissection in robotics is similar to open surgery, traction and counter traction. There's a little bit better access to lateral nasopharynx and parapharyngeal space. And because of the wristed instrument and the endowrist allows a more complex movement like suturing, which unfortunately usually we don't need to do, but it helps with the wrist. It gives a bit more dexterity. I think the other I didn't mention is a very stable endoscopic platform. I mean, a human being will have more tremor and instrument collision compared to a robot. But the disadvantage, of course, is a cost first. And secondly, is a limited lateral reach compared to an open nasopharyngectomy. And then it's a lack of tactile sensation. That means that you cannot identify the carotid artery with palpation. So nowadays, I use navigation and also visualization of the pulsation to kind of determine where exactly is the carotid artery. The other thing is there's a lack of bone instruments. So cases where they invade mainly to the spheno or the paranasal sinus or to the pterygomaxillary fissure, those cases I will use an endoscope. I will not advise you to use a robot. Robot is more for soft tissue recurrences. And it's also difficult to control bleeding from the pharyngeal plexus in the parapharyngeal space. And the technique of midline palatal split, where we divide the whole soft palate, may lead to a long-term impairment of palatal function. So with the XI, we only have 8mm instruments, which also has a bit of problem. And also with the current robot, we're only able to deploy 2 robotic instruments, except in the new robot, which I don't think I have time to go through today. So finally, I would like to thank Prof. William Wei, who started the whole project and asked me to continue, and all my collaborators in University of Hong Kong, in Intuitive Surgical, and Dr. Chris Holdinger from Stanford, who helped me to continue my project for the last 10 years. So I would like to stop my presentation here and take any questions.
Professor Sang, it was wonderfully how you have told about your experience, and it's really great to have you here with us.
Thank you. Nice to see you, Mudit.
Yeah. When I had talked to Dr. Thomas Low, and he referred straight away your name. So I told him I've already invited him. It's like that when you talk about nasopharynx, then your name always pops up here.
Thank you. I mean, I try to. I mean, very happy now, Prof. Low, working with him, and I can continue my career in a different part of the world.
So, Professor Sang, because you were previously using SP,
yes,
and now I don't know whether you have SP here or not.
I don't, unfortunately.
So
I have, yeah, SP is the best.
Okay.
Because it allows 3 arms and have one more joint and more flexibility. Unfortunately, the cost is prohibitive for us to get an SP. Even Hong Kong and Singapore doesn't have an SP. I think Taiwan doesn't have an SP. Yeah. So hopefully in the future, when the cost of cost of everything electronic will come down, we'll be able to use it.
Yeah. What about the drilling system? Anything in robot, they are putting something for bone? Because the skull base is one area where only soft tissue where robots can be put in. Any research is being done on that or anything, you know?
I don't think the robot company, because they're actually a commercial company, they look into profit. I think the technology is there. There is something called sonopet, which is a ultrasonic dissector for bones, but they haven't adapted it into a robot. So I know some skull-based surgeons do their bone resection using a sonopet, and also drills. I think technology-wise they can do it. It's because of the commercial that they did not. So nowadays, if I need, sometimes I do a combined approach. When the sphenoid, I use an endoscopic technique, and down in the nasopharyngeal or parapharyngeal space, I use a robot. Hopefully in the future, especially when we can develop cheaper technologies, that the robot is actually, the robot is and endoscopic are not mutually exclusive. They are the same category of minimally invasive skull-based surgery that just are complementary, I think. So robotic surgery, robotic nasopharyngectomy is a subset of endoscopic nasopharyngectomy. That's how I consider that. So I want to make the audience clear. This is not mutually exclusive.
That's true. That's true. That's true. So thank you, Professor. I would like that you should stay a little bit longer because we will have a panel discussion. We'll have your inputs
Definitely.
regarding
No
your
problem. No
management.
problem.
Thank you, Professor. And can you stop the screen, sharing the screen?
Oh, there are some questions. Can I
Yeah,
answer?
please.
Yes. So what's the minimum mouth opening for robotic approach? I would say at least 3.5. That's 3 thing of breath. Because if it is not big enough, even your instruments can go in, you don't have room to manipulate. Because we have to come from below superiorly. So we need a kind of diagonal trajectory. Position of the table during docking. With the Da Vinci XI now, we use a conventional, we just have to use the robotic arm facing superior instead of facing inferior. So the robot comes on the right side of the patient, and I set up the XI as a left side pelvis approach, but the robot will come from the right. Then the whole thing is going superiorly. So if the palatal suspension is inadequate, then the handler access in your if the palatal suspension is inadequate, I will use a palatal split approach. So palatal split, you will have much better access. But the problem is you have to close it meticulously to prevent any palatal fistula. Does ICG have a role? Yes, ICG do have a role, but unfortunately, my experience with it is until you are like 2 or 3 millimeters away from the carotid, the ICG, the fluorescence doesn't penetrate. So you can't use ICG as a start of the procedure. You have to dissect all the way to a pharyngeal space where you have a little bit of fat in between you, where you start to see a little bit of pulsation, and you want to ascertain exact cause of the carotid, then I use an ICG. But so that's how I sometimes use an ICG, but I actually like to use navigation more. So I use EM navigation with the EM generator on the table, on the operating table. I use the Medtronic EM navigation, and that will actually is a more accurate and compared to ICG. Any retractor I use for tongue, I just use the Dingman retractor. The Dingman retractor where they have the tongue blade and intubate the patient orally. I use a Dingman retractor. Of course, you can use if you space is a concern, a tracheostomy will give you a few millimeter more for your space because there's no ET tube. But for minimally invasive, I try not to do a tracheostomy for my patients.
Dr. Rajiv, are you there? Can we have your comments? Dr. Rajiv Sharan? Okay, Professor. I think we will walk through again some points when we are discussing cases in panel discussion. Thank you, Professor.
Thank you.
Yeah. Stop sharing. Can you stop sharing your screen, please?
Is it okay? I've stopped sharing.
I think.
Yeah.
It's okay. Thank you.
Thank you, Professor Raymond Sang, Dr. Rajiv Sharan, and Dr. Vipin Arora. Moving ahead, next we have a talk on role of endoscopic nasopharyngectomy and post-op complications by Dr. Shivakumar Tyagarajan, sir. And to chair this session, we invite Professor Kapil Sikka, Professor, Department of ENT and Head and Neck Surgery, AIIMS New Delhi, and Dr. Saurabh Arora, Director, Surgical Oncology Head and Neck Services, Max Super Specialty Hospital, Delhi.
Yes, Saurabh.
So Dr. Kumar is
Hello?
Yeah, I think Dr. Saurabh is not audible here.
Okay. Okay, Kapil, can
Am
you
I
continue? Yeah.
So thank you, Dr. Mudit, and thank you, Dheeraj, for nice introduction. I have been attending this webinar at the very comprehensive and very nice talks. So before wasting any time, I think may I introduce Dr. Shivakumar. He is a professor at TMH and ACTREC, Mumbai. And I would request him to start his talk on his insights in endoscopic nasopharyngectomy.
Yeah, thank you, Dr. Kapil. At the outset, like to thank the organizers for inviting me for this talk, and I just would share the screen and just go ahead with this. Okay, just give me a moment. I'll just start it. Yeah, is my screen visible?
Yes, you are audible and screen is visible. Please start. Thank you.
Again, I'd like to thank the organizers, especially Dr. Mudit Aggarwal, for this opportunity. So my talk is basically on role of endoscopic nasopharyngectomy and postoperative complications following that. We've had great talks so far. So just to recapitulate again, just to have the global scenario, we're all aware that the the CA nasopharynx is most common in China, the Southeast Asian countries, and certain parts of Africa. Coming to India, this is one of the lesser common cancer, less often seen cancers in our practice as of today, and it's most often cancers that we see in the northeastern part of our country, and also in our practice, the patients whom we see. There are majority of them who are coming down to TMH Mumbai from this part of the world. So recurrent nasopharyngeal carcinoma, 15 to 50, after treatment, 15 to 58% of patients might experience recurrence, and they would require to undergo retreatment. And only 1/3 of these recurrent lesions would be suitable for endoscopic procedures. We've seen a wonderful demonstration of the robotic techniques for nasopharyngeal carcinoma. So, of course, prior to that, it was the endoscopic approach, which was the first minimally invasive technique that was, started for nasopharyngeal carcinoma. But here the key is to ensure negative surgical margins like in any oncological procedure and avoiding accidental injury to the internal carotid artery. So patient selection is of utmost importance. So once we have any patients, with recurrence, because that's the topic for the day. We would, as always, the patient would be discussed in the multidisciplinary clinic, and you would consider various factors, the tumor factor, looking at the resectability, the proximity to the vessels, the presence of nodes, especially the retropharyngeal nodes as well, and whether the patient has only locoregional or disease elsewhere. And of course, you would also consider the prior treatment that has been received and the patient factors, whether how the age, the performance status, the comorbidities, and all these factors would be considered while we take a decision for treatment. And when there's a question of whether to go ahead with surgery or re-radiation, of course, as what Sarbani madam said, we would typically discuss these patients in our skull-based clinic, and we would consider the various all these factors will be looked upon, and then a decision regarding further treatment for these patients would be considered. So essentially, the classic nasopharyngeal, the undifferentiated of the squamous cell carcinoma, as madam said, the numbers would be really few that we would actually end up operating. And most of the nasopharyngeal cancers that we would end up operating would be the minor salivary gland tumors or non-squamous cell carcinoma histopath, or the non-undifferentiated classic nasopharyngeal type histopathology. So this is what we would probably end up operating more often than the classic nasopharyngeal carcinoma. So, it's been discussed enough that from anatomical point of view, the nasopharynx is a very challenging area to operate upon, especially because it's situated in the center of the the head, which is very difficult to reach and and also dissect. There are various open approaches which has been covered in the previous talk as well. I've just put them just to enumerate those approaches that are there. And of course, as was mentioned, the maxillary swing would be the most common open approach that would be used, if at all. So again, the endoscopic nasopharyngectomy was first described by the Japanese group, and then it has been taken forward, subsequently. And this was again alluded to by the previous speaker. Now, I just thought I just restrict myself to the evidences that are there which are favoring endoscopic nasopharyngectomy in the recurrent setting, and the technique essentially, as what was described earlier, is more or less the same for endoscopic technique as well. And essentially, for endoscopic technique, you would use a 2 or a 3-hand approach whenever possible, with a nasal endoscope and the usual skull-based instruments that you would usually use. So this trial has been mentioned at least twice so far. I think we cannot move. This is a very important trial, at least when we talk about endoscopic nasopharyngectomy. So this trial published in the Lancet Oncology in 2021, which compared head-to-head between endoscopic nasopharyngectomy versus re-irradiation in patients with recurrent resectable locally recurrent nasopharyngeal carcinoma. So over a period of over 6 years, 200 eligible patients were randomized with a median follow-up of close to 5 years. The primary endpoint was overall survival here. So essentially, recurrent T1, T2, and a few T3 cancers were included in the study. And what is important, it was shown that the endoscopic nasopharyngectomy in this setting had a better overall survival. The other very striking point was the deaths associated following re-irradiation, which Sarvani Madam also has alluded to. And endoscopic surgery significantly improved the overall survival compared to re-irradiation when it was considered resectable after the initial treatment. And the group also concluded saying that though it is better to and a few resectable T3 these commentaries that came following mentioned in these two commentaries, and based on that, consider endoscopic nasopharyngectomy mostly T1, T2 recurrent and a few T3 recurrent recurrences, and of course to perform these procedures. The other point here was left to physicians' discretion, and just about for more than that received the induction chemo, that were pointed out in these commentaries. So says that when this expertise is available, endoscopic so those were essentially for predominantly T1, T2, and a few T3s. And how about endoscopic nasopharyngectomy for T3 and T4s, even more advanced cancers? So you do have literature for supporting that as well. And this meta-analysis of published literature, mostly retrospective prospective series, wherein 1,600 plus patients with recurrent T3, T4 nasopharyngeal carcinomas were compared for when endoscopic surgery was done and IMRT was done. As you can see, more than 1,000 patients were treated with IMRT compared to 358 patients who underwent endoscopic resection. Despite that, the disparity in numbers, patients who underwent endoscopic surgeries did show to have a better 5-year overall survival, though there was not much difference in the 2-year overall survival. and the results supported the use of endoscopic surgeries even for recurrent T3 and T4 cancers. Now, one point that needs to be kept in mind here is that looking at the disparity in numbers, 358 and 1,200 plus patients, probably the kind of patients that were chosen for endoscopic resections might have been, they might have been more those who were considered resectable, and many who would have been considered unresectable could have ended up receiving IMRT. So that point needs to be kept in mind. But nevertheless, endoscopic surgery can be attempted in advanced malignancies as well, provided the expertise for the same is available and you could achieve a negative margin. So while considering endoscopic nasopharyngeectomy, one needs to consider what is when we are contemplating what is resectability, we need to understand that as well. So essentially, when the disease is confined to the nasopharynx, that is recurrent T1 lesion, and or posterior nares or nasal septum or superficial parapharyngeal space, recurrent T2, or when the lesion extends to the base of the sphenoidal walls, recurrent T3, or when the distance from the internal carotid is 0.5 mm at least. So in these situations, it's considered as a resectable area in a recurrent nasopharyngeal carcinoma. So you need to look for whether the disease is in and around this region for again, the previous RCT also was from the Stonekatian University from China, and this again is from the same group, wherein they had proposed a surgical staging system for patients with recurrent nasopharyngeal carcinoma, wherein they considered, apart from the T2A, what they divided it as T2 resectable or unresectable kind of a lesion, and they gave a different sort of a staging, surgical staging for these recurrent lesions. And they found that when it was surgically resectable, either stage 1 or T1, T2, so the surgically resectable T1, surgical resectable T2, in those patients, the outcomes were better, as seen in the Kaplan-Meier curves. And this is their workflow based on their surgical staging system. They would consider surgery depending on in the T1 and T2 lesions, and when it is extensive, then they would consider non-surgical treatment options. So what would be considered as contraindications for endoscopic nasopharyngeectomy is massive intracranial or intradural involvement, orbital content invasion, invasion of the pharyngobasilar fascia, involvement of the neural foramina and obvious perineural spread along those, extensive parapharyngeal space or infratemporal fossa involvement of the cavernous sinus, and encasement of the internal carotid artery would be considered as contraindications. Though we do come across series wherein even with the involvement of the internal carotid, some groups end up after performing a balloon occlusion test, embolizing the carotid and also resecting the carotid artery. But then it's associated with morbidity. But then that's done by a few surgeons and few centers. But then generally, it's considered as a contraindication. Certain points to be considered while we contemplate an endoscopic nasopharyngeectomy is that we should aim for the widest possible exposure to achieve complete resection and achieve a negative margin, at least a negative margin. The cut margin should not be positive. It might be 5 millimeters is ideal, but may not happen in all the dimensions all the time. However, we should aim for it. After resection, healing can be by secondary intention, but it's always best to put some local flap. Most often used flap is the Haddad flap. Whenever possible, the Haddad flap is raised, most often from the opposite side of the nasal cavity, and it is used to cover the exposed bone so that the healing can be much better rather than allowing it to heal by secondary intention. Temporalis muzzle flap also has been. Now, the preoperative workup here, of course, has been biopsy, prove it, and imaging, CT, MRI, many times we would consider during the procedure, especially when the lateral extent of the resection is going to. And of course, sometimes if the disease is closer to the, if carotid artery not done routinely, very few centers do it. I've not done it personally, but then we do perform balloon occlusion test if if the disease is going closer to the internal carotid artery, just to be sure as to if there is any untoward incidences would happen if there is a bleed intra-op or post-op. The option of doing the embolization or putting a stent across the internal carotid artery is a possibility. So for that we just would keep this. We would do this test beforehand. So the endoscopic nasopharyngectomy technically has been divided into 4 types. One being the type 1 being resection limited to the posterior nasopharyngeal wall, reaching to the floor of the bony floor of the sphenoid sinus. Type 2 being the resection where the superior extent is to include the anterior wall and floor of the sphenoid sinus. Type 3, when the extent of resection goes laterally, including up to the parapharyngeal space and the removal of the ipsilateral cartilaginous part of the eustachian tube. And type 4 is when there is an intracranial extension and you would go intracranially to complete your resection as well. And type 4 is also whenever a part of the internal carotid artery is resected between the paraclival or the parapharyngeal segments, that is also considered as a type 4 resection. So one needs to understand the principles of endoscopic surgical resection. It has been covered by the. It's more or less the same as what was mentioned in the robotic nasopharyngectomy. So patient selection is the key here, and we should have a suitable plan depending on the extent of lesion that is there. And the third hand technique that is to help the exposure better. A bloodless resection should be the key as much as possible. Stick to the surgical planes, and the dumpling technique, as what was described even for the robotic approach, is also used in the endoscopic technique. To do the nasopharyngectomy, and a the flap is used whenever possible, especially from the opposite side to cover the resected area. So after resection, there should be the intraoperative field should be examined for a proper resection, whether it's been done or not, and the specimen has to be examined. And you have to compare the resection, and look at the imaging to make sure that the entire field, disease has been addressed. And also after resection, it is important to follow these patients, at regular intervals, because there are certain problems that you would expect in these patients, even if there are not many intraoperative issues that were there, you would expect certain problems that I'll just allude to in the next few slides. So the post-operative care is very essential. Nasal douching is recommended at least 3 to 4 times a day to avoid the crusting once the patient is discharged. So that that is an essential post-operative care that needs to be advised, and a frequent is recommended at least once in care. Otherwise, if not done properly. So, of course, all minimally invasive is avoided compared to what is described in the This is one of the again a very important post-operative issue that is encountered after an open nasopharyngectomy. So again, you would, especially the maxillary swing approaches. So that is these are some of the advantages of doing an endoscopic nasopharyngectomy. Coming to complications, the most dreaded complication is the internal carotid artery injury intraoperatively in the immediate period, or a blowout subsequently. That's why it's very essential to cover after, especially the type 3 sort of a nasopharyngectomy with some sort of a flap. At least the Haddad flap needs to be put in place, and subsequently nasal crusting, I just have mentioned, so that needs to be taken care of, preventive as well as, like douching and, doing a endoscopic suction toilet. A post-operative headache has been described in literature following these endoscopic procedures, and it's been said that the incidence could be minimized, especially with the use of adult flap and not allowing the surgical bed to undergo healing by secondary intention. Serous otitis media is another complication. It's it's a issue with nasopharyngeal carcinoma per se, but then after nasopharyngectomy, especially when you remove the eustachian tube on the ipsilateral side, that's a problem which can be tackled with putting in the ventilation tubes. Epistaxis postoperatively, if there's excess of crusting, and that could be one of the problems that can be seen. Xerophthalmia is seen secondary to injury to the median nerve after the procedure. And CSF leak could be one of the issues. Osteomyelitis, these osteomyelitis are seen in the long run, and then cervical spine abscess also has been described, and numbness over the V2 distribution. So these are some of the complications that one may encounter following nasopharyngectomy. Some in the immediate, some in the later part of the surgery. So this is one article wherein the quality of life of patients following salvage nasopharyngectomy was assessed. It was a prospective series where they did a baseline assessment and in the follow-up using the anterior skull-based questionnaire and the sinonasal outcome test tool, and they found that compared to the baseline at 3 and 12 weeks there was a drop in the quality of life, but then at 6 months and 1 year the quality of life came back to the baseline, suggesting that a good endoscopic nasopharyngectomy can help achieve a decent quality of life that the patient had prior to surgery. However, subtotal resection was associated with a worse overall quality of life at 6 months and 1 year. So that quality of life which was getting better after, at 6 months and 1 year might not happen if the resection is subtotal. So to conclude, I would say that endoscopic nasopharyngectomy is a very feasible option for recurrent nasopharyngeal carcinoma, provided it's at centers where the expertise is available, because it's not a straightforward procedure. It's a complex procedure to perform. Proper case selection and surgical planning is essential to minimize complication and maximize the results that one would want. And post-operative morbidity and mortality seems to be acceptable, provided it's done at centers where the expertise is available. Thank you. Be happy to take questions.
Thank you, Dr. Shiva. It was a very elaborated. Yeah, thank you, Dr. Shiva. It was a very elaborated presentation. Most things you have covered already, and I think the one thing is the staging T1, T2. We should not look into that extension of the disease before taking patient for nasopharyngeal endoscopic resection. Dr. Kapil, you want to say something?
There is only one question.
And the questions in the chat.
There is only one question in the chat that I can read, and it's regarding what is your comfort level in regard to distance from the carotid artery when you are doing case selection. I think Dr. Shivakumar mentioned in his talk that some centers do even the encased carotid artery resection. But what is your protocol, sir?
So at least we would try to have a 5 mm distance from imaging. The MRI is what we usually do. But I've seen people resect the internal carotid artery after embolizing it as well. But then at our center we would try to have a distance of at least 5 mm. But here I think if it is closer than that, probably the approach might differ. Maybe as what the previous talk the speaker said. You would probably do an open approach rather than endoscopic. Probably that's what I would do. Maybe with different centers with different level of expertise might do things differently, but then that is what we would do.
Fine, good point. So thank you so much. And if we don't have any questions, we can move on to next session. Over to Dr. Mudit, please.
Thank you, sir. Thank you, Shiva, sir. Thank you, Professor Kapil Sikka, sir. And thank you, Saurabh, sir.
One. 1 minute. Okay. Hello.
Moving ahead, next is a panel discussion on management of recurrent nasopharyngeal carcinoma. The session will be moderated by Dr. Mudit Aggarwal, Senior Consultant and Head, Department of Head and Neck Surgical Oncology Services at Rajiv Gandhi Cancer Institute. And the case presentation will be by Dr. Shreya Rai, FHNO Fellow at RGCRI.
Hi. Hello. Good afternoon. I think we have covered most of the aspects of nasopharyngeal cancer, but as I told initially that we are not seeing many patients of nasopharyngeal cancer, and it is primarily a disease of radiation oncologists. And we as a surgeon have come in recently after trial has come in, but it was there initially if we go to Hong Kong and China where they are managing it. So salvage nasopharyngeal has been always there. But now because of evidence has come in, so things have more streamlined. So we'll just discuss how the things we are at our institute, how we are managing recurrent, and we would like to have opinion from all the national and international faculty so that we can be more wiser in managing our patients in the near future. So I would like to invite Professor Alok Thakkar, who is presently the head of the department at ENT and head and neck surgical oncology at AIIMS. He is known for his GNA work and is a versatile surgeon, and will definitely and he will definitely enrich us with his expert comments. Welcome, Professor Alok Thakkar. Now, Dr. Reggie Thomas is a professor and head of unit ENT, and he runs a skull-based fellowship at his center at CMC Vellore. And I welcome Dr. Reggie Thomas for this panel. Dr. Saurabh Arora is a dear friend. He's a senior consultant and director of surgical oncology of head and neck surgical oncology at Max Healthcare. Dr. Shiva, already you heard him that he has spoken on endoscopic nasectomy and he does more of skull base. So he has already told most of the things, but still practical aspect we'll discuss with him. And I welcome you, Dr. Shiva. Dr. Amit Bahel, who's a professor, Department of Radiation Oncology at PGI Chandigarh. So it's a very busy center there, center in Chandigarh. So we'd like to have how the things of constraint, how the same planning is being done, or is something different, or how do you go about managing these nasopharyngeal. Welcome, Dr. Amit. Dr. Praveen Lawat, he's with us. He is a consultant in Department of Radiation Oncology, and we have organ division in radiation oncology also. So he's in head and neck department in radiation oncology. Welcome, Dr. Praveen. Dr. Atul Sharma is professor and head at Department of Medical Oncology at AIIMS. So it's really a pleasure to have him on Sunday, and I'm really thankful that he has given permission to be with us. Welcome, Dr. Atul Sharma, for this panel. Dr. Meenakshi Kamboj, who's a senior consultant Department of Oncopathology at our hospital, and she will tell us about some inputs about pathology as a surgeon we face. Dr. Manoj Gupta, he is a senior consultant Department of Nuclear Medicine at Rajiv Gandhi, and he is a wonderful guy. We go all in for discussion of most of the cases, we go to him, and he has some insights which we usually miss out in when we see it. So we'll welcome him. Thank you. Next. So Dr. Nitin is a attending consultant in Department of Radiology. So whenever we plan a case, we go to him about critical analysis when we do for a case. So all these things, he will guide us when we are discussing our case. Thank you, Dr. Nitin. Sure.
Good morning, respected seniors. Thank you, sir, for the esteemed faculty introduction on the panel. We start with the first case. The first case is a 41-year-old male from Dimapur, Nagaland, with no comorbidities and diagnosed case of nasopharyngeal carcinoma. He was clinically C T3N1M0. He received radical CTRT, 70 gray, 33 fractions, and 7 cycles of cisplatin from 9th October 2020 till 28th November 2020 at Nagaland. He presented to Rajiv Gandhi in November 2021. No presenting complaints and no significant examination findings of oral cavity and neck.
So, because in this, whatever details we could not get was whether the patient underwent neoadjuvant chemotherapy or whether patient underwent adjuvant chemotherapy. So what's the consensus among our radiation colleagues? Dr. Praveen Lawat, how do you go about? Do you give all the patient neoadjuvant chemotherapy, or you just stick to adjuvant chemotherapy, or when do we do that? Or Dr. Amit Bahal, and Dr. Munish, anybody who can pitch in, and Dr. Sarbani, what's the protocol for management of nasopharyngeal cancer in a neoadjuvant or adjuvant setting? Or Dr. Atul Sharma can also pitch in.
Until few years ago, I think 2-3 years ago, we used to routinely give adjuvant chemotherapy. But now there is more and more consensus that it is better to give as a neoadjuvant setting and then give chemo radiation. So now, at least in our hospital, we're gradually shifting to induction chemotherapy and then radical chemo radiation.
Okay. Dr. Amit at PJ Chandigarh.
I'll also agree with him. Majority of our patients are stage 3, stage 4. Rather, our practice is more confined to stage 4 cancers. And we were also practicing radical CTRT followed by adjuvant chemotherapy for 3 cycles. But now we have changed our protocols and we are going for induction chemotherapy for 2 to 3 cycles using GEMS protocol followed by radiation or concurrent CTRT.
I would say at AIMS for the last probably decade or decade and a half, our standard practice is we have been using paclitaxel and carboplatin most of the time. The reasons basically are because we were many times were not able to give the cisplatin 5 post in adjuvant setting. Number 2, many of these patients who come with the symptomatic disease and they would require control of the symptoms. They would come with the cervical nodes. And logistically also many a times we found that the scheduling them for early radiation was little challenging. So probably instead of waiting for this thing, we would give neoadjuvant chemotherapy followed by CTRT.
Okay, I think most of we are practicing neoadjuvant chemotherapy. Professor Loh, any changes in your place, Singapore, Professor Sang? What do you plan? How do you plan neoadjuvant or adjuvant chemoradiation?
Our treatment protocol is neoadjuvant. We do not actually give adjuvant chemotherapy. The results are there, and the tumor actually shrinks remarkably after the chemotherapy.
Okay, I think it's
I can represent Hong Kong. I mean, where I used to practice for the last 25 years. So yeah, we did quite a bit of trial, the Hong Kong nasopharyngeal cancer study during the early 21st century. We tried to see if adjuvant helps, but we found out that it turns out adjuvant is not useful. So nowadays, for advanced T staging or even advanced nodal staging is induction chemotherapy, but we used gemcitabine and cisplatin because it's found to be more effective, and less toxic. Right now, it's going a trial in Hong Kong is to randomize between gemcitabine, cisplatin, and gemcitabine, cisplatin plus immunotherapy as an induction setting. But the trial is still recruiting patients. So I think by the time I left the study, we recruited around 80 patients. So it won't be a few more years before we know whether addition of immunotherapy is useful for induction setting.
Okay, right, Professor. So now, because as most of the patients are treated by radiation oncologists, so Dr. Amit, Dr. Praveen, and Dr. Munish, how do you follow up these patients after the treatment? Dr. Sarbani, how do you follow up these patients? What is the follow-up protocol? You yourself follow it, or you refer it to surgeon to follow up it? How does it make? Do you do imaging? Do you do endoscopy? What do you do it?
Can I answer this question?
Yeah, ma'am.
Yeah, so at the TMH, what we do is after 3 months of the initial therapy, that is the first definitive therapy, what we do is after 3 months of completion, all patients undergo an endoscopy followed by an assessment scan, which includes both the PET-CT as well as the MRI and all the other functional tests that we do, that is the ophthalm, the PTA, the hormonal evaluation and things like that. After that, at follow-up, what we do is the patient undergoes clinical evaluation and endoscopy. And once a year thereafter, the patient undergoes an MRI of the face neck, including the base of skull and the PNS. We do a PET CT thereafter only if clinically indicated or the MRI is equivocal. And we, of course, do the TFT every 6 monthly for our patients and the PTA every year.
Okay. So once you image the patient after treatment, and after that you will just keep on clinical follow-up.
Clinical, and once a year we would do the MRI.
Right. Okay. Does it see if we see a patient who is early nasopharyngeal cancer versus who is a locally advanced, imaging will change, or is it same?
So most often we keep the same imaging protocol, but of course for the advanced stage nasopharyngeal cancer, the threshold for doing a PET CT at the slightest indication or suspicion of a recurrence is slightly lower. We would jump to doing a PET CT earlier than for an early case, in which we would rely more of the endoscopy and the MRI.
Okay. Okay. Thank you, ma'am. What about Dr. Amit at your place in PGI Chandigarh?
We follow a protocol where we also evaluate the patient about 3 months. And first, the patients are evaluated by our ENT colleagues, and a full endoscopic evaluation and clinical evaluation is done. And generally, then we'll go in for imaging, one of the imaging to assess the post-treatment. Generally, we prefer an MRI or a CCT. That again is only done in case there is any suspicion of recurrence or there is some finding on our MRI or CT which warrants for the evaluation.
Dr. Mudit,
yeah,
you know very well that we usually do, as Dr. Sarvani said very rightly, that baseline after 3 months PET CT and MRI, and then at least for 2 years, I personally doing 6 monthly MRI, apart from other TFT and other these tests, but 6 monthly MRI and as and when required, nasopharyngoscopy as well.
Okay. So, Professor Low, what do you do? At your place, radiation oncologists themselves do examine nasopharynx, or they send it across to you? How is it? Because early recurrences matter.
No, at our practice, it's usually followed up by us in the otolaryngology head and neck surgery. And every visit that there's a touch point with us, we will examine the nasopharynx. And so the protocols that have been mentioned by everyone is pretty similar. And so patients will be followed up very regularly, probably 3 to 4 times in the first year after treatment. And the scans are done within the first 4 months. And usually we're more concerned with the nasopharynx and therefore the MRI than a PET CT. The PET CT scans would be done within the first year after treatment, and it's largely to look for distant metastases. And thereafter, the question begins how much advantage you get from a very systematic annual scans. The question then starts to come in, and as you probably realize in Singapore, the cost of healthcare is a big issue, and therefore we have to start answering these questions in a more systematic fashion, and we don't necessarily do regular scans for someone after some period of time where they are well and there's no evidence of disease, in particular if they've gone past 5 to 6 years of treatment. The only other issue, of course, is whether we use plasma EBV DNA as a follow-up. The answer is that it is a very good, useful follow-up after treatment to see that it has declined significantly. But again, as mentioned by our colleagues here, it is difficult to know exactly what constitutes an abnormal EBV DNA in a setting of post-treatment. Over.
Okay. So do you feel any role of narrowband imaging while doing endoscopic examination? Does it help? Or do you use it, or it's become a part of it? Hello, Professor Alok?
So we do use narrowband imaging as part of a routine follow-up if we are worried. But my own impression is that it hasn't worked so well in detecting disease at sites wherein we are not suspecting it. It is a specific localized area where you're looking at. Certainly, it may enhance your suspicion.
Okay. Okay, sir. Thank you.
Mudit, the problem with NBI is that after radiation, the vascular pattern, whether it's an abnormal pattern or not, and I'm not to an NBI. So, and I guess where over.
Right. Okay. Okay. Thank you. Thank you.
So I think if you go by literature, the MRI and CT is not very helpful, but MRI is little better. But sensitivity, specificity, if you see the PET scan is better than the even MRI in the recurrent cases. Yes, the structural disease. If you find out that the recurrence is there, then MRI is a good modality. If you already detected the recurrence, then you have to see the extent of the disease. But we usually do the PET scan yearly. Endoscopic 3 to 4 monthly and the PET scan yearly. And if we think that it is a recurrence and we find out and then we do the MRI.
So we'll do endoscopic examination with PET CT scan.
Endoscopic every 3 to 4 months, but PET scan yearly.
Okay. Dr. Manoj, can we have a word from you regarding the role of PET CT in follow-up?
Sir, I think like in our institute, what we do at the first evaluation at the 3 month of post-treatment. So we do a PET CT scan, and if the PET CT scan is negative, then it has a very good prognostic value. The chances of recurrence is very, very less in a 2 years time. So it has a very high negative predictive value. So this we need to keep in mind. And in the follow-up, and definitely if your endoscopy is suspicious, your clinical suspicion is high, definitely we can add a PET CT scan, or sometime MRI. If it is suspicious, we can add a PET CT scan. But at 3 months, it is definitely a yes. Or maybe advanced disease where you suspect a disease recurrence up to a year, then you should use a PET CT scan as well.
Right, right. So I think more or less, so anything particular you look into, Dr. Manoj, when you see a PET CT of a nasopharyngeal carcinoma, any particular NFL?
Sir, I think the most, the site of recurrences we see is the lymph node. Sometimes we see the lymph node in the retropharyngeal area or a neck node. So those areas we need to be very careful. And even in the nasopharynx, we have, with the experience, we have come to know that sometimes the muscles, the back muscles, they become activated. And then you have to be careful when you're reporting a PET CT scan that you should not mislead with this muscle hyperactivity. You have to be careful. So that's why any focal activity is important, because the muscle is normally a linear longitudinal activity. So you can take it as a physiological activity. So any focal activity in the nasopharynx area or in the retropharyngeal area or in the neck, then that should be, our area of, cautious.
Right. Okay. Thank you, Dr. Manoj.
The patient had already undergone nasal endoscopy and biopsy outside, and the biopsy outside was reported as poorly differentiated SCC. Biopsy review at Rajiv Gandhi was suggestive of non-keratinizing undifferentiated nasopharyngeal carcinoma. Thus, we did a repeat nasal endoscopy, PET scan, and MRI of the patient. The lesion is clearly seen in the left nasopharynx on nasal endoscopy and PET with approximate pre-op planning of the surgical margin, and the MRI suggestive of ill-defined enhancing thickening involving the fossa of Rosenmuller and the torus tuberous more on the right side.
So, Dr. Meenakshi, is the role of, what do you suggest, the role of EBV DNA in follow-up of such patients? We still feel, because there's a dichotomy of opinion regarding the role of EBV. What is your opinion regarding that?
Yes, Dr. Mudit, the role of EBV plasma DNA for quantification of viral load is important, but it is important if you do it before the treatment. We need to know the baseline level, because there is, as Dr. Thomas was saying, there is no cutoff value that we know what is the number of copies that is needed for the diagnosis. So at our setup, the PCR that we do, we can detect as low as 316 copies to as high as 10 million copies. So we don't know but at what range is the cutoff for the nasopharyngeal carcinoma. So for these patients, before you start the treatment, if we have a baseline value, then we can use later on for any recurrence and for monitoring the treatment, we can use this test then to see if the value is rising or it is stable or it is reducing. So it is important to have a baseline value also for this test. It's a very
like serial
sensitive
rise or serial dip will indicate that whether recurrences are there or not.
Yes, and
Right.
it is a circulating DNA, circulating virus. So it is shed from the tumor cells. So only if there is a tumor mass, and if it's a mass is a bigger size, it will have an increased number of copies. So that's how it is done.
Okay, thank you, Dr. Meenakshi. So now coming
Dr.
to
Mudit, Dr. Mudit, ma'am. Dr. Mudit.
Yeah.
So,
Yeah.
Dr. Mudit, so in this case, the biopsy was positive, but if it is a very small recurrence and the biopsy is negative, then I think there is a role of LMP1, EBV LMP1, the protein it has a very high sensitivity and specificity, and in those cases, if that is positive, the most of the chances that the patient has the disease, and if it is also collaborated with the scans. Is
because
very
this
informative.
patient scans are almost nothing type. Is positive. Only
Yeah.
a small speck you can see that whoever has done it, I think beautifully they have detected the disease very early. That's what I can say. This is what we intend to do with the follow-up of these patients should be like that you pick up the disease very early with high index of suspicion. That's what Professor Lowe was telling. And you're saying if these are biopsies negative and if you are clinically suspecting that disease is there, then you can do further testing.
Yes.
So Mudit, can I say something here?
Yeah, Dr. Sarvani.
Yeah, we often use the pathologist actually and for these small things to actually do a neighborish on the tissue that we've biopsied.
Yeah.
And of course, in addition, you can do LMP1, but we ask our pathologist, the molecular pathologist actually does an neighborish on the tissue.
Yeah.
So that, because if we don't have serial EBV titers,
Yeah.
as has been said by several speakers, we really do not know the implication of EBV. And sometimes our patients also, depending on the test that we have done, we may not get plasma EBV positive and it may really not be able to tell us anything. So on the tissue, you could do an Eberish.
Right. So Dr. Meenakshi, your word, do we do that?
Yes, Eberish is a very good marker and we routinely do for all the diagnosis and if biopsies come for any recurrence. And sometimes even if it's a very less 2 or 3 cells, which they are very well lit up with this marker. So it's a very robust marker.
Yeah, so we do it in our setting also. So now coming to the next question, because the patient will be with the radiation oncology team. So how should we proceed further? Dr. Praveen, Dr. Amit Bair, Dr. Sarvani, in these patients?
Until 2 years ago, the routine consensus was to irradiate. But now after the recent trial has come up, which says surgery, if it is a resectable, surgery is better than RT. So in this case, if it is a resectable disease, expertise available, patient willing, we should go for resection first. If for any
Dr. Amit,
reason,
Dr. Amit, anything?
Yeah, so such patients are generally evaluated in our combined modality team. And in this case, I think since radical radiation has been given, surgery could be one option, first option for managing this patient. And if surgeons are somehow not willing for surgery for any logistic reasons, then of course radiation is always available for these patients.
I might have missed. Did we do the metastatic workup?
Yeah. So we did a PET CT.
Okay. This was
PET
a
CT was done, MRI was done. Yes. And it was only a localized disease here.
Got it.
Yeah. So, and Dr. Sarvani, what would you suggest?
Patient like this, as I see the PET scan, there just seems to be a speck in the right. Is it I think the fossa of Rosenmuller, or actually it's very anteriorly located, even in that area, and it's just a speck. So I would definitely evaluate this patient and have the surgeon opine on the ability to do an R0 resection.
Right. So what do you think? Like previously, 3-4 years back, were you thinking of sending the patient to a surgical colleague, or you were just rereading this patient?
No,
What
so
was the
even
yeah,
then, we used to send it across to our surgeons because, in keeping with re-radiation anywhere in the head and neck, we would always ask our surgeons to evaluate for surgery if feasible with acceptable morbidity. That would always be our
right?
philosophy.
Okay. So now, we have come over to surgeons. Now patient has been referred to us. Professor Alok Thakkar, how will you go forward, sir?
So yeah, it's been a couple of years since the patient had his last treatment. The recurrence seems very small and resectable. It's away from the carotid. It doesn't seem to be intracranial disease. There's no pain. So yes, surgery is a good option for the obvious reason, and even otherwise for salvage, the first option is surgery if it's resectable, and this is. We have more evidence now, courtesy Dr. Sang, Dr. Kaur, that also tells us that endoscopic surgery is doing better than re-radiation. So I would certainly look at surgery. Traditionally, we have done the maxillary swing approach, and we have been doing it for a fair number of years, though numbers are very small. We have been very careful with the endoscopic approach for two reasons. A, with oncology, you want to be a little bit radical, and B, competence. But we have done the endoscopic approach in 2 patients, and this patient also, I would feel in the current scenario, would merit an endoscopic nasopharyngectomy, looking at where the lesion is.
Right. Dr. Reggie, word about from you. How will you manage this patient?
First of all, I want to thank you for allowing me to be part of this. So I've learned much. As far as I can see, this is a very limited tumor. It is limited just into the one zone of the nasopharynx, and it's not going too much in the parapharyngeal space. I would definitely consider endoscopic nasopharyngectomy. This would even be a type 1 or at most a type 2, and we would be able to.
Dr. Shiva.
The margins are open, at least.
Yeah. Okay. Dr. Shiva, what would be your approach?
Yeah,
and what are the things you will think like might be happening in post-op setting, or what do you think? Or you will straight away plan surgery for him? What will be your approach for surgery if you're doing? Yeah.
I think the workup has been pretty much complete here. I think I do agree with the plan of endoscopic resection, and it looks very much feasible as what Dr. Reggie said, a type 1 or max type 2. And definitely I would want to do an Haddad flap from the opposite side and use it for a cover after the resection. I don't see much of a problem with this particular case that we are discussing. I think it's very much doable with an endoscopic approach.
Right. Like if patient says I don't want to undergo surgery, he's afraid of getting surgery done. So now again this patient goes back to radiation oncologist. So re-radiation, as Dr. Sarbani has told that you can radiate. So which will be the preferred modality if you have you are in best center of the world? You have all the paraphernalia available. Which type of modality you are going to use? Brachy, you're going to use SBRT, IMRT for re-radiation of this patient? Dr. Sarbani, you are in the best center of the world.
No, I'm sure Amit and all treat equal numbers of patients. So in my center, with my experience, what I would like to do with this patient is do IMRT.
Okay. Okay.
I don't believe in SBRT, and the evidence for SBRT is there. It's not that it isn't there, but it is not as strong or as robust as well-done IMRT. Of course, if I tomorrow have the proton beam therapy functional at my center, I may choose patients to go for proton beam therapy because I would expect that the side effects and the late morbidity would be much lower with the use of proton beam therapy. But as of today, it would be IMRT or VMAT.
Okay. Okay. Any other difference in opinion from other Dr. Amit?
I would agree with Madam. I think I would go in for IMRT using VMAT for these treatment. That's what we usually do. It's a very confined disease. I'll say a kind of an ideal situation to re-radiate the patient, and we'll be able to achieve the OAR constraints and everything in such a case. That will be a good modality, and we might not even need to use concurrent chemotherapy. With this kind of small disease, we could get away with radiation alone.
Right. So now patient says that I've already had so much side effects of radiation therapy. I don't want radiation also. So Professor Atul, can you help this patient out by any new advances, immunotherapy, targeted therapy, this patient?
So basically, like everybody had discussed, the ideal treatment would have been the surgical resection. If not possible, then the radiation without chemo. But if at all that also he doesn't want to have, then the only option available is that probably the systemic treatment. Now, the systemic treatment, there are a couple of advances. Probably we have the phase 1, level 1 evidence to say that the gemcitabine platinum is superior to cisplatin 5-FU. That it becomes obvious choice, much better tolerated, responses may be higher, and so on. So that is one thing. Coming back to the question of the recent advances, unfortunately for the nasopharyngeal carcinoma, the targeted gene like EGFR inhibitor, which we have been using in other head and neck squamous cell carcinoma, did not show much of the improvement. So that becomes kind of undoable. We don't prefer that. Once agent, another Indian EGFR inhibitor, nimetuzumab, there is some data about that also, small tyrosine kinase inhibitor, that also. Coming back to your question and regarding the immuno-oncology drug or immuno-checkpoint inhibitors, which have been shown improvement or shown their efficacy in various solid organs, including the squamous cell carcinoma, unfortunately, what are available in India have not shown much efficacy, like nivolumab and pembrolizumab I am talking about. But there are 3 Chinese molecules which have been, and they have shown in the phase 3 study, that means the level of 1 evidence that they are superior to chemotherapy alone with regard to the response rate and improving progression-free survival. There are 3 agents for which we have the phase 3 data: tislelizumab, pembrolizumab, and toripalimab. So these are the Chinese molecule. Probably, to my understanding, they are not available outside China as of now. But as and when they are available for the selected patient, probably they will be useful.
Right, sir. Thank you, sir. So for the surgeons now, everybody agrees that we will go for endoscopic approach?
Yes, I agree.
So in which scenario would like to go for an open approach? From everyone, Professor Alok, as you have more experience in open approaches, what do you feel, where you would like to go for an open approach rather than going for endoscopic surgery or?
No, honestly, my advice is do the approach that the center is comfortable with. I certainly won't advise to switch from one approach to the next. As already mentioned by many, and certainly don't, probably safe for centers in big centers in Guangdong and so on. I think most centers would be exactly what you all said, that most will not be. It's not like we do such surgeries every week in, week out. So my advice is stick with the method that most are comfortable with in that center. And this can be an endoscopic approach. It can even be a transoral robotic approach too. Yeah.
Right. So, Professor, what margins do we aim at when you do a nasopharyngectomy? Is it more than 5 mm or a centimeter?
I guess except for me to say that in nasopharyngectomy, the tool is determined by the carotid artery. Raymond?
For me to mark the gross tumor is around 5 to, it's seldom a centimeter. You might get a centimeter in the over the medial margin, but the lateral is probably 5 millimeter. So I would say anything negative is fine for us. Because, for example, on the clivus, it's basically the mucosa and then the peripheral fascia and then the bone. So the deep margin, you always only be one layer of fascia. I mean, so that's our take. I think I want to follow up on the question of whether open endoscopic. I think nowadays majority of the T1-2 can be operated with an endoscopic. When I would do an open is when the tumor is big and I don't like piecemeal, I want on-block resection, then because the margins will be assessed better, then I'll do it. For those big tumors, I'll do an open. And if the tumor is on the carotid and I need to dissect it off the carotid sheath, I still prefer open approach where if there's a bleeding, I can at least use my finger to press on it.
Right. So are these patients who are having a parapharyngeal extension, you feel you have to resect it, are these patients not suitable for re-irradiation, or you still consider them for surgery?
Depends, really depends. I mean, most of the time, if it is not close to a carotid, I think we can operate. The problem is the carotid artery is not constant in the parapharyngeal space. Some people that are very medial sometimes. So even a medial tumor can have the carotid. I mean, so because the carotid is very variable in it, so it's not so much of a. You have to look at the scans. I mean, it's not so. Sometimes those very medialized carotid, I tend to do the open surgery and then cover it with a muscle flap, usually the temporalis or free vasta lateralis muscle.
Okay, it's a free temporalis you're talking about, or the pedicle temporalis?
No, pedicle temporalis. Free flap would be the vastus lateralis muscle, the muscle on the thigh.
So what do you say it's like absolute contraindication where you will not go in for surgery, like local disease, not the regional one?
Local T4, definitely T4.
Yeah.
Gross marrow invasion into the clivus, because I don't think you can get clear margins with that. You might be able to burr around that bone, but then you just bury the cancer cells deeper into the bone, I think. And then I think into the foramens, as Sven mentioned before, into the foraminus of the skull base, because even though I know people have been doing it, but the results are not very promising, because a lot of times they also have perineal spread along the nerve into the intracranial, but into the brain, and you can't get a clear margin.
Shiva, in your book, what do you call its absolute contraindication?
Yeah, as I mentioned, I mean, intracranial extension, and also, the encasement of the internal carotid artery or going towards the, cavernous sinus, all these, or orbital invasion for that matter. So all these things, I would probably not consider for surgery. I would call it inoperable.
Okay. So where if the parapharyngeal extension is there, you will still go ahead and do surgery for that patient. If it's, you can say 2 mm away from the ICA, you will.
But then again, we need to be very complete with the workup, and also the approach might change. I may not be comfortable with endoscopic when it is very closer to the carotid, as what was being mentioned. Maybe I would choose to do an open approach, but then it is we would consider surgery in that case. Until and unless if it is encasing the carotid, I would not do the surgery in that case.
Okay. Professor Alok, sir, what do you say that you will not go ahead with surgery?
So this obviously depends also on a discussion with the patient as to what is his expectation with regard to response or cure. And you don't really have a very high rate to offer there. So it obviously depends on the patient's condition. But in terms of anatomy, certainly if it's skull base erosion or carotid abutment, I would have significant concerns. Even a maxillary swing approach doesn't give you too much confidence with the ICA. You don't quite see it. You know where it is. You have a feel, it's just behind the lateral pterygoid plate. You could use image guidance, but obviously, there's going to be no margin there. So distance from the ICA gives you confidence. Lack of pain gives you confidence, because that indicates that clinically the skull base isn't involved, and lack of radiological involvement of the skull base gives you confidence. Beyond that, you have a discussion with the patient, and if the patient is willing to move forward with an operation which is less likely to have a positive outcome, you may still move forward. So,
Professor Alok Thakkar, would you like to go for a robotic approach or still comfortable with endoscopic and open approach?
My baseline approach would always be the open approach. This is oncology. You want good margins. In this situation where there is only mucosal involvement, I am confident to consider an endoscopic approach wherein you take the tensor and levator veli pillati and get fair deep resection and depth. So that is it. Robotic, I have no experience with. We are a very low volume site for this kind of thing, and I would not want to get involved with malignant disease in a salvage setting with the new procedure.
I think right, Professor. I think you have said that your first priority will be to get a margin negative disease rather than getting a margin positive disease. And as everyone has that, first of all, oncological principles need to be followed. Then approach can be decided depending on the comfort and experience of the surgeon. So if you are comfortable with endoscopic, you will go for endoscopic. If you're comfortable with the open, you will go for open. Or robotic, as Professor Sang has a major experience, then you can combine robotic as well as endoscopic approach. So depending on that, we go for it. So other word about the retropharyngeal node. So if you, as I had asked Professor Low also, that if you have a case with the retropharyngeal node, it's a difficult problem actually. Sometimes what happens, you have isolated node, your primary is almost gone, your nodes are not there, but there's node in the retropharyngeal. How do you people approach a retropharyngeal node? You operate, you go for radiation therapy? Professor Alok?
So again, very difficult to differentiate a retropharyngeal node from recurrent disease based on the PET scan. You don't quite know what's happening. I rarely see that well-localized disease. Is always diffuse disease on the scan. If it's the isolated retropharyngeal node and nothing else is happening, I may consider surgery. If with surgery I see a node, I would take it. I would probably consider an open approach rather than endoscopic approach, because the robotic approach to the tonsil has limits to how high you can go out there.
Okay.
I would probably, you can get to the retropharyngeal node even by a neck dissection, by cutting the styloid complex and the digastric. But all said and done, you're obviously looking at very, let us say, low chances of a successful outcome.
Yeah. Professor Sang, you have any experience regarding this?
You mean retropharyngeal lymph nodes?
Yeah. Any robot?
I have limited experience. I've done my second case this week earlier.
Okay.
But it's not, it's a retropharyngeal lymph recurrence of olfactory neoblastoma, not an NPC.
Okay.
My experience with NPC, it's more difficult. Usually the dose to the NP is very high. The lymph node is quite stuck down to the carotid. My preference is still open maxillary swing. When I isolate the carotid, I'll control it and then dissect it off step by step, like how you do a very difficult neck dissection, a recurrent. When you try to dissect a lymph node recurrence of a recurrent neck dissection, I mean, it's similar to that. There is only one person I know that have a lot of experience, is Professor Chen Mingyun in China, where he does endoscopic nasopharyngectomy, but when he goes for retropharyngeal lymph node, he'll use the robot. He has probably like maybe 20, 30 cases experience, but because his center is the highest volume, I would say it's a difficult procedure, dangerous.
Right. Okay, Professor. So, so now what happens? What about the reconstructive option in these patients, like local reconstruction, Dr. Shiva? Like after doing a nasopharyngectomy, you plan your flaps initially, or if you plan, you harvest the flap initially and park it somewhere. How do you do it?
So I think if I plan to use a Haddad flap, I would start with the Haddad flap on the opposite side, and so that I'm sure that the vascularity of the flap is, so I'm certain about the vascularity, and park it on the side. I'll be doing it on the opposite side. So raise the flap and park it on the side, and then address the disease on the other side that is there. That would be my approach most often.
Okay, Dr. Reggie, any word about how we do it?
Actually, my experience in nasopharynx stems from other pathologies.
Right.
I have a limited experience with malignancy, and even with malignancies, it's mostly hemangioperitocytomas and adenocarcinomas, which are radioresistant.
So
but then definitely I have reconstruction options, because reconstruction options definitely Haddad flap, but I would definitely park it in the maxillary sinus of the opposite side.
Okay. So, Professor Sang, how do you do it?
Flap to hang in my way, but handling plywood models, because we go into and temporalis flap definitely is definitely a reserve option. The temporalis muscle. If it's a very large defect, then I would go for temporalis muscle.
Okay, okay.
Normally for small, I use Haddad flap most of the time. But I found that Haddad flap is not very, especially in the post radiation, it's not very robust. Sometimes I have around 20% flap lost. So if it's mission critical, that means the carotid is exposed. I definitely need to recover it. I'll use a muscle flap, either a temporalis or a free flap.
So can I make a point here? If the going to be exposed, if you're talking about type 2 or beyond, then definitely a free flap. But I was talking about the Haddad if for a type 1, at best for a type 2 kind of a nasopharyngectomy. But if the carotid is anywhere in the vicinity, I think it's definitely best to put a flap, probably a free flap.
Okay, okay. So
the other point which I could contribute is if you see our ICG scans, you can find out on the vascularity of the other flap. It's well described that you can use the ICG to look at the vascular.
Right, right. Nice point.
But the flap is going to be viable. So one option that you have.
So I think that's what because Chen initially had described that he will harvest the flap after the resection. That I could not understand. Usually we plan beforehand and we harvest the flap, and after that we do so that the vascularity doesn't get compromised. But he in his article has written that he will go for a resection and followed by reconstruction and then harvest the flap. So that's why I wanted to have opinion how you do it. So so we know that both of the modalities do very well, re-radiation as well as endoscopic, and we already talked about that's outcome already. So EBV also. So now we come to the so this patient underwent endoscopic nasopharyngectomy, and as everybody is told, but we were not feeling comfortable raising a Haddad flap because margins, I was thinking the margins were getting compromised. So we didn't raise a Haddad flap in this patient. And same, we have used coablator in this because bleeding is relatively less if you use coablator. And the word what I was worried about when you are coming on the superior lateral area of the nasopharynx, where your lateral carotid will be there. So how do you manage that area? Because that's the most difficult, tricky area I found that bleeding can be there. Professor Alok, any encounter with that? Because lesser area is very tricky there, because I had, when I was doing it, so we had bleed also there, but we could manage locally.
So I have limited experience with the endoscopic technique. I agree that I would use a coablation, but I would think that perhaps Dr. Reggie Thomas or Dr. Poe in the interest of time could really tell us how they would take this forward.
Dr. Reggie, any word about how do you manage the lateral one? Because when you go lateral to the, when you take the eustachian tube margin, definitely your carotid will come. But lateral foramen also is a tricky area when you, superior lateral area when you come.
Okay, the foramen lacerum is definitely attached to the eustachian tube.
Yeah.
And the cartilaginous fibers have a dense attachment to the foramen lacerum. So if you're going to have a malignancy that is going to get stuck onto the foramen lacerum, that will be practically like an invasion of the carotid. This thing, I mean, the artery is involved. You have to treat it that way, because then if you're going to venture into the foramen lacerum per se, you need to get a superior control and inferior control. And for me, when I talk about superior and inferior control, it's definitely exposing the paraclival carotid, which usually we do with the neurosurgeons, and opening the neck and get a control below. So that's the only proper control that you can get on the carotid above and below when you are handling the foramen lacerum segment. The key to getting closer to the foramen lacerum segment is that you don't disturb too much of the attachment on the cartilage onto the foramen lacerum. Coablator is very useful, and it's better to avoid a monopolar there, because you don't know where the current goes and you can get into trouble. So you should ideally use a bipolar and avoid a monopolar and use coablator, because coablator again functions like a bipolar. And so you keep a thick layer of fascia between the cartilage and the foramen lacerum and try not to sect into the foramen lacerum.
So any experience with the bleeding in this area? How do you manage this? Like
Pardon, I couldn't get your
how do you
question.
manage the bleeding if it happens, bleed is there? So how will you tackle endoscopically the bleed there? What all things technically you will use?
Yeah, one of the major bleeders that arise are the median artery. Median artery bleeds do come from that region, which can be controlled with the bone wax and with the diamond drill, the median artery bleeds. The rest of the bleeds are mostly with surgery foam and or flow seal. We tend to use that. And that will take care of the venous bleeds. And it's better to avoid a carotid bleed direct. And you have to be very careful how in depth you want to dissect there.
So other thing is, like, if you want to identify, if you don't have this identify the ICA, how many people go for like median nerve drilling and you go below that? Dr. Shiva, any experience regarding that?
Not exactly. So I would rather take the, drill the lateral pterygoid plate and of course have that as one of my landmarks. But I wouldn't. And then if I'm doing a type 3 sort of a resection, yes, I would do that. But I've done it less often.
It's a safer, it's a good guidance you give, get to for a safer, to avoid injury to ICA there.
So I would look at a trans-pterygoid approach, find the vidian, follow the vidian, stay medial and inferior to it, drill the pterygoid so that you get access to the pterygoid fossa behind the pterygoid bone, and then probably stay medial to the medial pterygoid in this situation and take everything that is lateral to it. And if I'm sort of medial to medial pterygoid, I'm generally comfortable also with regard to the ICA and sort of try and take that. So I very much like the videos. I saw the robotic videos with the dumpling technique.
Yeah.
It seemed to make so much sense as to how you sort of wrap it all around the tumor and take it out. And I would look at the lateral extent, the lateral resection first, or the depth of the resection first, and then take the tumor off it. And superiorly, the vidian. Superiorly, the vidian could be a border.
So,
could I add a few points onto that? The parapharyngeal ICA has been of interest to many of us doing endoscopic work. As Dr. Alok pointed, we have looked at a series of patients where trying to map the internal carotid, and we have found that above the C1, which is a soft palate level, and it rarely comes onto the midline. So if you stay below the C1, it can actually come straight onto the midline as a rare cases. But above the C1, which is approximately the floor of the nose, it always is medial to the lateral to the medial pterygoid plate. And as Dr. Alok pointed, if you say medial to the medial pterygoid plate, you're very confident that you're not going to come near it because that's the plane of the paraclival carotid, and the parapharyngeal will not come near. Once you go lateral, the landmark that I tend to use is one is if I have a navigation, I have the approximate depth of the transverse process of the C1, then that tells me that the carotid is right in front of it. And that being a bone landmark is very stable because at least navigation, I know the depth. But the other landmark which I find useful is the levator palate muscle, which I identify on the soft palate, and I trace it up because that levator palate muscle actually inserts onto the carotid tubercle, and the IC is right behind it, and that's a very good landmark if it is not really tampered by the disease and by surgery. So if it's a very clean case where it is identified, it's a clean case where you can identify the levator palate, and you can stay anterior to it, then you can avoid an injury to the carotid.
Right. Yeah. Thank you to Professor Reggie. So this patient was followed up, but the same problem, histopathology, didn't show any tumor there, but it was there on the biopsy and slide review, and margins definitely were all clear. And patient is just on follow-up. And so the problem still is with that crusting problem is still there with this patient, and he has to go for regular cleaning at his place there in Nagaland. So is it has to be there, or how do you tackle all these problems? Because there's a major problem which patients are having. Or is it just a side effect which will have when we do nasopharyngectomy? Yeah. Dr. Shiva, how do you do it?
So
how do you manage these patients?
That is bound to happen because we are creating that sort of a cavity there. I mean, we are doing all the structures and it's a cavity, and crusting is one thing you expect, and that's what, as I mentioned, we need to do. Ask the patient to do nasal douching in the post-operative period. And at regular intervals, you might want to do, the endoscopic suction toileting as well. So it may take at least, 3 months or more till the time that there's, some amount of crusting that is reducing, or it may even take more depending on how big a cavity that, left behind inside the nasal cavity. But yes, that's a problem in the postoperative period that needs to be tackled.
Right. Okay. Thank you, Dr. Shiva. Second case.
So I'll log off. Mudit, I'm sorry, I need to be somewhere. Very sorry, but it's been a great
Right.
educative.
Thank you, Professor. Thank you, Professor Alok. It was really nice that you had spared some time on a busy schedule.
Please move on.
Sir,
Please move on.
yeah.
Yes.
Thank you, sir. Yeah. You'll move on to second case.
So the second case, 31-year-old female from Dimpur, Nagaland with no comorbidities and diagnosed case of nasopharyngeal carcinoma, CT2N0M0, received radical CT-RT till August 2019. She presented to RGCI for follow-up, no presenting complaints and no significant examination findings of oral cavity and neck.
So we have already, Professor Atul has already told about the role. So I wanted to ask Professor Atul anything about in oligometastatic setting role of chemotherapy. How do you manage oligometastatic role in nasopharyngeal cancer?
Can we go back to previous slide?
No, it's just not related to the case. I will just tell you that a patient is having an oligometastatic disease, like one deposit is there in the lung with a recurrent disease. So how do you go about it? You will go for a total palliative,
I
or
probably also request that probably the radiation colleagues, whether it's suitable for the single lesion, suitable for SVRT or some high dose radiation and thing. Now, of course, probably this will be probably followed by systemic treatment, understanding that this is a systemic disease.
Okay. Dr. Praveen Lawat, what is your word about oligometastatic disease? Has it a term is there oligometastatic in NPC?
Sir, recently it has picked up. This issue has come up with good research that unlike in other head and neck cancer, we do not have any evidence for going for a radical treatment in oligometastatic setting, but in nasopharynx we do have. If we have oligometastatic sites, we can still go with radical chemoradiation, but after giving some amount of chemotherapy, if they're responding well, we can treat the local site with chemoradiation with a very good result.
Okay. So this patient underwent nasopharyngectomy, and we tried, this was the patient which we are talking about. And I will just tell you, we underwent a nasopharyngectomy and she had some problem because I tried going orally as well for giving an inferior cut using a robot. And we had a palatal dehiscence in this patient post-operatively. And patient is post-operative, you can see the defect there. Patient is doing fine. But the post-op complications, I want to, she had a persistent neck pain. I really don't know. She was having a terrible pain in the neck and which persisted for at least 3-4 months. So any idea why she was having pain? I could not get into it. Any other panelist having come across symptoms like that? Patient post-nasopharyngectomy having pain in the stiffness in the neck.
Actually, that's quite common. That's the necrosis of the osteomyelitis of the spine. Sometimes they become unstable. Patients need the orthopedic to do a posterior spinal fusion. And then we debride the anterior, either endoscopic or open, and then put a free flap, muscle flap to cover it, vascularized tissue to cover it.
Okay. So this patient is still, so this is the post-op. You can see that post-op on imaging, this endoscopic examination after a year. Only granulation tissue is there. And what happens that we get worried that it's a recurrence or it's a granulation tissue. So I don't know, any imaging is not helping us. So how do you tackle this in post-op when you do endoscopic examination of these large cavities? You will see granulation tissue or whether disease. How will you know? What is your index?
You're right. It's difficult. It's difficult because PET scan, because of osteomyelitis, PET scan, they will be hypermetabolic. MRI will also show inflammatory changes. So it's difficult. I mean, judicious biopsy plus follow-up monitor with the EBV DNA. Now, having said that, for us, for the EBV DNA, the median level for nasopharyngectomy is 50. So we need a very sensitive test to see what, I mean, so anything, if it's a rising trend of EBV DNA, then we worry there's a recurrence. But a single setting may or may not be useful.
Okay, okay, Professor. So this scan, I will, so follow-up scan, again, 3 months follow-up scan was negative and 6 months scan was done, CT spine. Dr. Nitin, can you read about this scan, Dr. Nitin?
Yes, sir.
Any typical thing you are seeing in the scan? Because she's complaining of neck pain.
So there is a basically an ill-defined erosion of the clivus bone, sir, and there is a ill-defined soft tissue lesion.
Yeah, I think that's a, and can you show the PET scan? Dr. Manoj, can you comment on the PET scan we did for this lady and we were worried she was having neck pain? Why is it?
So I still remember this case when you come to me that the patient is complaining of severe pain. And when I scroll this scan, I see, the odontite process. So if you can see if you can scroll the again and you can go down.
Yeah.
Now from here, you can see, there's a diffuse activity which is seen along the odontite process. The margin of the odontite process is irregular. So I suspected there's a osteomyelitis which is happening to this particular area. And probably some kind of infection which is happening here. And the activity is not that high. I will suspect a residual disease or recurrent disease. I was more suspecting a infection in this area.
Yeah. So, so as Dr. Sang told that because we had just done few cases, so we came across this condition, and you people have done such many. So that's why, and we found that it's ORN mostly because we have not done any reconstruction for this lady. That's why she presented with this. But now because of antibiotic and anti-inflammatory, this condition is stable. It's not increasing. So she is not ready for any kind of surgery, and she has been maintained like that only. And it's much improved, but still she's complaining that she's having that. Other problem she had was video. Okay. So any of the panelists, have they encountered ORN like that, which we have seen in the surgical practice? And how do you prevent or manage these pain? Main is management of ORN. Dr. Saurabh?
So for the ORN, skull-based ORN is a very lethal disease actually sets in. It's not a kind of we see in the mandible. It's much worse, the skull-based ORN. So actually, good antibiotics, regular cleaning, these are the first stage we have to do. If that doesn't work, then you can do some debridement also if looking like a necrotic tissue is there. And the rest also we can try the hyperbaric oxygen therapy also.
Yeah, right. That's true. Dr. Reggie, anything you will suggest us? Osteomyelitis?
Actually, Mudit, Dr. Mudit, this is I have a huge series of central skull-based osteomyelitis, which is my primary area of research and interest, surgical interest.
Yeah.
And we are a center that has huge volumes of central osteomyelitis in diabetics. We don't have too much of ORNs, but we do have a huge number, and nasopharyngeal excision to access the clivus and the petroclival fissure is sort of a every week procedure. The volumes have gone up so much. So I presume you can use the same principles in laryngology, is that we take targeted biopsies. The correct focus of the disease is targeted, and we get cultures from there. And based on that culture, we give them specific antimicrobials for minimum of 6 weeks, at times up to 3 months. And that we have found is very useful.
Right. It's good actually. Actually, usually, yeah, we need
central osteomyelitis.
Yeah, because we think of antibiotic course for around 7 days, 10 days, or 2 weeks time. We never think of that we go for antibiotic course for 3 months or so. I think what the point you have raised is quite relevant.
It has to be a targeted biopsy which actually brings the correct specimen for culture. If you give regular broad spectrum for anti-Pseudomonas, anti-staph, we found a lot of fungal osteomyelitis developing in those patients. And we find sequestrum in aspergillus all coming up because patients have had empirical antibiotics for a long term.
Okay. Okay, right. I think it's a nice point you have raised. Professor Sang, Thomas Low, any experience with this? How do you manage this condition?
Osteoradial necrosis, the problem I have has always been very often I can't get any growth in bacteria. The treatment is antibiotics. The treatment also in the last 5 to 10 years or so, I am of the firm belief, and we just actually published our data, that these patients are at high risk of carotid blowout. Because the ORN will just continue, albeit in a very slow manner, and eventually they'll lead to the erosion of the carotid artery. So we are very concerned about such patients, and so where it's possible, we'll put a flap in. And most of the time, we think that the nasal septal flap, if it's still available, then we use it. Yeah.
Okay. Because you're right. I think it's worrisome to have ORN in that area where ICA is there and carotid blowout can happen. Dr. Sang, any experience? Your experience? What do you say? Your same philosophy?
Yes. As early minor, we treat it conservatively with repeated endoscopic toileting plus long-term antibiotic. It means up to 3 months. Usually it's a generic augmentin. We get a mixed growth a lot of time with the culture. A lot of them also can be due to the actinomyces, which you need to see in the biopsy. A culture can't grow it. For more severe ones, we do endoscopic debridement plus nasal septal flap to cover it, to let it epithelialize. For very severe ones, we treat it really like a recurrence. We do open maxillary swing, debridement, and free flap to cover the exposed bone. We have actually some cases who actually develop epidural abscesses from these ORN, and we need to combine with our neurosurgeons to manage them. It's tough. So we tend to avoid it is to try not to give second radiation, and also if we do surgery, cover the defect and don't expose any raw bone.
Right. So I think whenever we are planning surgery, some sort of reconstruction should be done to cover the bone. Otherwise, chances of osteonecrosis will be there. That's what I feel, that once, because initially we were feeling a little bit hesitant using Hadad flap because oncologically we might not feel that good margin if you take it. But I think some sort of reconstruction needs to be done in this defect. Otherwise, chance of ORN will be there. Thank you. And if you see with IMRT also, the chance of recurrence, I will show you this post-op cavity. You can see there's a lot of crusting is there, and that small area of exposed area is there here, or that odontoid process area. But now it's collapsing with time. It's not such a big area. So the problem with this young girl is that she is having that decreased hearing, that serous otitis media will be there. So how do you manage this condition? Means, do you put Dr. Shiva?
Yeah.
Because she is now not hearing properly from the side we operated on the right side. How do you?
I think we need evaluation, just check as to what is the nature of hearing loss that she has, whether it's purely conductive or there is a mixed component to it, because these patients have already received concurrent chemoradiotherapy. So know actually what kind. Of course, there'll be a conductive component to it, but then you need to know whether there's a sensorineural component as well, because you need to counsel the patient accordingly. If there is, we will have to put in a ventilation tube there, to give her, the patient, some sort of relief, and also give a realistic counseling based on what we see on the audiogram.
So, Professor Sang, Professor Low, do you put in a draining tube for like government?
We don't. We have studies showing that it actually increased the risk of radial necrosis of the temporal bone area. So we just, and also it causes a lot of discharge and infection.
Yeah.
But that study was done in the pre-IMRT era, where the cochlea and the middle ear has a much higher dose. But since then, we don't, and we usually just give a hearing aid for the patient.
Okay.
I mean, nowadays, maybe we can revisit it again with IMRT. The dose to the middle ear may be much smaller than before.
Okay. So this patient, I think hearing it will be better because it will become a wet ear. After that, draining will be more in these patients. And other problem she's having is velopharyngeal.
Dr. Mudit, so last year, 2 patients, they are primary patient for nasopharyngeal carcinoma. We have done chemoradiotherapy and they presented with the otitis media.
Yeah.
And we have done the biopsy and put a tube at the same time. But they are fine in the follow-up. But they were not the recurrent cases. They were like upfront chemo-RT cases.
Okay.
Yeah.
Okay.
Yeah, Dr. Mudit, I'd like to say something.
Yeah.
So in the MRT era, I think we can, with VMAT and this, we can control the doses to the cochlea quite well. And there will be some component of conductive hearing loss with some effusion in the initial post-op radiation period, but generally it resolves after some time. Sensorineural component can be controlled. As far as the radiation component, it can be controlled with good VMAT. Of course, some sensorineural component is because of the concurrent chemotherapy, cisplatin-based chemotherapy. Of course, that is there, but radiation part, we can control the doses to the cochlea very well now.
Okay. So other problem which patient had was a velopharyngeal incompetence. So she you see the quality of voice she is having. So what can we do about it? So any opinion about how can we rehabilitate this patient? Because now she's having, because her voice has improved, because mostly it looks like because of palatal insufficiency she was having little bit, is having. So how can we do anything about it for her? Either surgically, medically? Yeah.
I was thinking about referring for an obturator.
Okay.
Surgery will be difficult because the tissue is scarred.
Yeah.
Trying to do a palatal flap, probably there's not much tissue in the wrist of usually I send them to my max fac surgeon and see how they manage it.
Actually, if you see in the oropharyngeal carcinoma, also if you give chemo-RT in those patients, there's a lot of scarring in the soft palate, and velopharyngeal insufficiencies also there in those patients also. It's not only with the nasopharynx carcinoma. And most of the time, whatever you do with time, they adjust to it. Most of the time, what I've seen, patient know how to speak and when, how much. So it's patient adjusted themselves to the things other than what you do most of the times.
Okay. Because actually she is young and married. So I was rethinking whether should have gone for re-radiation rather than I do surgery for this patient.
One of the things which we tend to be careful is when we work on the nasopharynx, the central part close to where the soft palate comes to close. Traditionally, the Passavant's ridge, even though that's not difficult, that's not easy to identify. The approximate location where the soft palate closes the nasopharynx off, that area we try to preserve the the bulk of that area. We try to dissect around it. This is learned from experience, because once we preserve that, the chances of below BP insufficiency is a little more lesser. This comes primarily from working with spine ortho who wants to get the organoid processes out before they fix the spine from behind. So when we work in that area, we try to preserve the bulk of the and whenever we encounter it, we usually involve the plastic surgeons to help us out, because they are more adapted.
Right.
BP insufficiencies for
thanks.
Lots of techniques in which they come and help us.
Okay. But what happens post-radiation, the reconstruction and all the thing, little bit healing issues are there. So, I would like, because I think we have exceeded the time, and my team members and other people are, we have exceeded time. So, if anything is there from our panelists, they would like to give some home points, Professor Loh and Professor Sang, for regarding this, because we have learned a lot from you, from your experience, and I would like to thank you all. But please give us some any words of wisdom which you are working on future of nasopharyngeal carcinoma management. Hello, Professor Loh.
Oh, thank you very much, Dr. Mudit. I can only say that my major take-home point actually is that I've learned from many of you today that we share quite a lot of commonality in the problems that we face with recurrent nasopharyngeal carcinoma. And I also see that the approach that many of you take towards the management is entirely very reasonable, and in a lot of ways, I feel that a lot of what we do in Singapore is pretty much justified because there's a large pool of experience here in India that actually justifies a lot of things that we are doing. Perhaps that we are in the right direction. Thank you.
Thank you, Professor. It was a pleasure having you with us. And I think we're coming to the end. I thank Professor Sang for giving his valuable inputs and time especially on Sunday. So I wish you a best of Sunday for both of you. And I thank Professor Sarbani Lashkar, Dr. Shiva, and my esteemed panelists, Dr. Alok, Dr. Reggie, Dr. Saurabh, Dr. Praveen Lawat, Dr. Amit, Professor Atul, and Dr. Manoj from the Institute, Dr. Minakshi, and Dr. Nitin. And not the least, so my thanks to my team. Dr. Shreya is there, Dr. Dheeraj, Dr. Anshu, and Dr. Abhishek, Dr. Sonam, and on last, but Mr. Ronak, who is our coordinator, who has compiled everything, and we have been doing things for all this. And Dr. Nidhi ji, who has been who's a coordinator for oncology, and she takes care of all webinars and all CMEs which we do in Head and Neck Oncology Forum. So I thank on behalf of Rajiv Gandhi Cancer Institute and Delhi Head and Neck Oncology, part of Oncology Forum, to all the esteemed panelists, speakers, international and national. And it's really a worthwhile learning for me for this type of rare cancer which we are treating. I thank you all the panelists, Dr. Munish, who has been with me to designing all the program. Thank you all. Thanks a lot.
Thank you. Thank
Bye.
you.
Thank you.
Good night. Goodbye. Goodbye.
Bye.